names of the hypothalamic hormones. Quick. Bolo, bolo. Say the names one by one. Hypothalamic hormones. Growth hormone is a hormone from the pituitary. Why are you talking? Why so much noise? Silence. Just one person answer, bolo. ACTH is not a hormone from the hypothalamus. Yes, hypothalamus releasing and inhibiting hormones to the hormones of the anterior pituitary, and not only anterior. So what are the hormones of the, okay, tell me the names of the hormones of the anterior pituitary. This is from school level knowledge. This is today's class, hormones of pituitary, but growth hormone. First hormones of the anterior pituitary are growth hormone, anterior. Then thyroid stimulating hormone or growth hormone is GH. Okay. ACTH, adrenocorticotropic hormone or corticotropin. Now what is tropic hormone? What do we mean by that? What do we mean by the term tropic? সব সামনের দিকে, পেছনের দিকে ওরা ওই কারণে গিয়ে বসে। ট্রপিক হরমোন মানে কি? হোয়াট ইজ ট্রপিক হরমোন? Tropic hormone is a hormone which stimulates, which stimulates some other gland to secrete some other hormone. That means which is stimulating some other gland. So ACTH is a tropic hormone, corticotropin, because it stimulates the adrenal gland, adrenal cortex to secrete cortisol, produce and secrete cortisol and sex steroids, which is the topic of discussion in today's class. TSH is another tropic hormone, thyrotropin. So thyrotropin stimulates the thyroid. Then LH, FSH, gonadotropins, acts on the gonads. Okay, so these are the tropic hormones, and other hormones of the, some other hormones of the pituitary, anterior pituitary. Growth hormone is also a tropic hormone in a sense. It acts on the liver and all. Okay, so growth hormone will be a separate class. So but which of the hormones of the anterior pituitary is not a tropic hormone? Growth hormone is a tropic hormone. Prolactin. Prolactin is not a tropic hormone. Prolactin is a hormone of the anterior pituitary, but it's not a tropic hormone because it does not, although it is, what is the function of prolactin? Okay, we'll come to that. So I was first asking about the hormones of the hypothalamus. Now those hypothalamic factors which influence the secretion of these hormones are the hypothalamic hormones, and those are also tropic hormones because they are influencing the pituitary. So they are called hypophysiotropic hormones. This was the last class. So if you are blank from the last class, it's no point going forward. So these are the hormones of the hypothalamus: CRH, TRH, GnRH, GRH. GIH is also called somatostatin. This is, everything is all this is from the last class. PRH, PIH. We had told that PRH is, existence of PRH is somewhat doubtful, right? Prolactin, PIH, the inhibiting hormone, that is, we know of that, but PRH is doubtful. PRH, prolactin releasing hormone, existence of this is doubtful, still under research. So who will influence the secretion of prolactin from pituitary? Which is, so if PRH is doubtful, then something must be there for prolactin secretion. So that is TRH. So the hypothalamic releasing hormones can stimulate more than one hormone from the pituitary. Like TRH is influencing both the thyroid pituitary for TSH and also for prolactin. Okay, so they have ACTH have actions on, okay, at least you remember that TRH is one of the releasing factor. Earlier it were called releasing factors, releasing and inhibiting factors. GIH, PIH are inhibiting factors, but now they are called hormones. Okay, they fit the definition of hormones, they are coming. So the connection between the hypothalamus and the anterior pituitary is vascular. Connections are vascular. These pictures were shown. See, median eminence is a part of the median eminence is a sac-like structure at the base of the forebrain, where above which the hypothalamus is situated. Median eminence is the area from where the hypothalamus releases those releasing and inhibiting factors. Those were discussed. See, the areas were discussed. All this is, sometimes this it does not work. See, prolactin, PIH is from arcuate nucleus. We discussed all these things. Growth hormone, somatostatin, periventricular nucleus, paraventricular nucleus, all these nuclei and areas of the hypothalamus we spoke about. These are the different areas and nuclei of the hypothalamus, and from we had told that there is no, as PRH is non-existent means not doubtful existence. So if a MCQ comes, arcuate nucleus secretes, then better not to mark PRH. Don't mark PRH, mark the others from the arcuate nucleus, somatostatin, GRH also coming. Somatostatin is GIH, growth inhibiting hormone, also secreted, same chemical secreted from pancreas, which has other functions there. In the GI system, the function is different. So this is a quick revision of the last class. So the hypothalamic releasing and inhibiting. Now these are the below the hormones written below are the pituitary hormone, ACTH, TSH, TSH, LH, FSH. LH and FSH are together called gonadotropins. Gonadotropins, growth hormone, prolactin, all these are hormones of the anterior pituitary. And what are the hormones of the posterior pituitary? Oxytocin and vasopressin. Vasopressin in the humans and some other mammals, it's called the arginine vasopressin, and in some animals, instead of arginine there is lysine, there it is called the lysine vasopressin. Now we had discussed why AVP and OT, that means arginine vasopressin and oxytocin, are called hormones of the posterior pituitary, although they are actually secreted from where? From the hypothalamus. The precursors are secreted from the hypothalamus, and the connection between the hypothalamus and the posterior pituitary is these connections, mainly neural connections. So there are cell bodies in the hypothalamus, cell bodies of neurons in the hypothalamus coming down, those axons are coming down to the posterior pituitary. Connections are neural. So unlike the anterior pituitary, where the hypothalamic hormones are coming via blood through the hypophysioportal vessels, the anterior pituitary gets a blood supply which are portal vessels. What is the meaning of portal vessel? The portal system of circulation. What is the meaning of that? It's a true portal system. True portal system means a system which begins in capillaries and ends in capillaries without passing through the heart. It's secondary physiology, not even higher secondary, a secondary biology. A system of circulatory system where it starts in capillaries, where that area starts in capillaries, ends in capillaries without passing through the heart. That is a portal system. This is a true portal system, hypophysis, not this one. This one, connection between the hypothalamus and the anterior pituitary. So it's not passing through the heart. From the hypothalamus, it starts in capillaries and also ends in capillaries in the anterior pituitary. This is the blood supply, and through this system, the hypothalamic hormones are coming to the anterior pituitary. But in case of the posterior pituitary, hypothalamus, the connections with the hypothalamus is neural connection. So the magnocellular neurosecretory cells, which is written in the picture, magnocellular neurosecretory cells, those are in the supraoptic and paraventricular nuclei. There are different nuclei in the hypothalamus. All names you don't have to remember now, but you have to read in anatomy, of course. So supraoptic and paraventricular nuclei. Of course, to mention the hormones, you have to know the names of the nuclei. Arcuate nuclei secreting hormones, other nuclei. So, but for the posterior pituitary hormones, it is the supraoptic and paraventricular nuclei. These two hormones, the cell bodies are called magnocellular. The name is magnocellular. So that those cell bodies in the magnocellular neurosecretory cells, neurosecretion, this is neural type of secretion formed in these cell bodies of these neurons and coming down the axons. During this transport through the axons, the precursors are being converted into the actual hormone, oxytocin and vasopressin. And then from the pituitary, they are leaving via blood route to act in other areas. So then it fits the definition of hormone. In definition of hormone, the hormone is a chemical messenger which travels through the circulatory system, through blood, not through the nervous system. So these are not called hormones of the hypothalamus. This can be a explain why type of question in the exam. Okay. Oxytocin and vasopressin is actually produced in the hypothalamus, although in the precursor form, but produced in the hypothalamus, but these are not considered hormones of the hypothalamus. Whereas, say, any example of a releasing factor, releasing hormone, corticoid, CRH, GRH, all these are hormones of the hypothalamus. Why? Because from the hypothalamus, they are living through blood, but these are not living through blood. These are living via neural tracts, axons of the magnocellular, these magnocellular cells, nerve cells. This is clear? So oxytocin and vasopressin are ultimately hormones of the posterior pituitary. Now what are their actions? So vasopressin is also called, its better name is antidiuretic hormone, because that is its primary function in the human body. We consider that antidiuresis function is the primary function of ADH in the human body. Okay. And why it is called vasopressin? Then because it has a pressor action. Pressor action means pressor, PRESSOR. Pressor action is constriction of blood vessels to cause increase in blood pressure. But that is not the primary action. Primary action is antidiuresis. So better name of vasopressin is antidiuretic hormone. So this is the primary, secondary. So it mainly acts on the collecting duct, target of posterior pituitary. See in this, it mainly acts on the collecting ducts of the kidneys. Renal physiology is yet to be done. It acts on the collecting ducts of the kidneys to reabsorb water in the medullary interstitium. Water is reabsorbed into the medullary interstitium of the kidney, and thus urine becomes concentrated. Concentrated means urine osmolality will increase or decrease. If it becomes concentrated, solute is increasing. So osmolality, this will be asked in the first internal assessment. What is the difference between osmolarity and osmolality? not today's class. No further discussion on this till the 15th. Everything will be asked in the exam. What is the difference? General physiology is complete, GI is complete, CVS is complete. So if you can't tell concentration increasing means osmolality increasing or decreasing, then nobody can tell. Concentration increasing means osmolality increasing or decreasing. So one person can tell in the whole class, rest will fail. So urine osmolality increases, and as water is reabsorbed, plasma osmolality will decrease. So it acts on the mainly on the collecting duct, but also on the distal tubules. Renal physiology is not done, there is, but I think you know this basic structure of nephron. Basic structure of nephron: ascending loop, loop of Henle, descending loop, distal tubule, collecting duct. Mainly acts on the collecting duct, but also on the to some extent on the distal tubules to reabsorb water and cause antidiuresis. Diuresis is loss of water, loss of not only water or solutes to urine. Diuresis, what are diuretics? There was a question in your senior batch, there was a question in the first prof exam. What are diuretics? 2 marks. So diuretics are any agents which increase the volume of urine, not necessarily water. It may be solute also. Say water is not increasing, but the amount of solutes in urine is increasing. That will increase the urine osmolality again, solutes. If water increases, osmolality will decrease, but if solutes increases, osmolality will increase. So there are 2 types of water diuresis, but more common is water diuresis. There may be also solute diuresis. When you drink a lot of water, if we drink a lot of water after dinner, we have to wake up at night to go to the toilet, because this is more amount of water is passing out. So that is water diuresis. This is more common, but there can also be solute diuresis. That means diuresis is the increase in volume. Diuretics are any agent which increases the volume of urine. So this is a bit of renal physiology. So antidiuresis is its opposite. It will decrease the volume, and in this case it is decreasing the water diuresis. So unless otherwise mentioned, commonly diuresis means water diuresis, but it can also be solute diuresis. Okay. So it acts on the collecting duct. It is its primary function. It also decreases medullary blood flow. So this is the primary function, and it also decreases medullary. Medulla is the inner part of an organ. Mainly we speak of cortex and medulla with respect to the kidney and the adrenal glands. So it increases blood flow in the renal medulla. Okay, it's not written over here, just note it down. It decreases renal medullary blood flow. Don't take pictures, I'll go to jail. These are from standard textbooks which should not be reproduced. Do you know there is a thing called copyright? Books can't be xeroxed, but we do so. In India, copyright means right to copy, but not elsewhere. So 2 functions, one is antidiuresis, primary function, next is decreases medullary blood flow, next is it causes glycogenolysis in the liver. So so there are 2 types of vasopressin. Still now 2 types, 3 types actually, at least 3 types of vasopressin receptors have been identified: V1A, V1B and V2. And so effects of antidiuresis are through V2 receptors. Other effects like glycogenolysis in liver is through V1A receptors. And it also stimulates, that is the third one. So how many functions we have told till now? 3. Primary is antidiuresis through V2 receptors in the kidney, in the nephron. then decrease of renal medullary blood flow, glycogenolysis in the liver, then ADH has an action on the anterior pituitary. ADH is of the hormone of the posterior pituitary. It is not a tropic action. Tropic action means it is going to another gland. ADH has acts on the anterior pituitary. It is not a tropic action, but it is just an influencing action to secrete ACTH from there. Ultimately, in that way, it indirectly influences the production of aldosterone. Okay. So what is the function of aldosterone? We will read in adrenal when we study adrenal cortex. So aldosterone restores sodium and water. So antidiuretic hormone itself is restoring water, and it also indirectly restoring water through aldosterone. So because it is influencing the anterior pituitary to secrete ACTH. Aldosterone is a hormone from the adrenal. ACTH will now, through its tropic action, it will influence the adrenal cortex to secrete aldosterone. So this is the fourth function. Don't say ADH's function is to secrete aldosterone. It is to influence the anterior pituitary to secrete adrenocorticotropic hormone. And last one is, sorry, not last one. These are the four functions of antidiuretic hormone. The last one is, of course, the which I mentioned at the first. 5 if you tell, then that is not a physiological function. In physiological levels, antidiuretic hormone can't cause this vasopressor action. That means increase in BP. It is at high doses. That means AVP is administered from outside. That is pharmacological doses. Pharmacology is a subject of in your second prop. You will read about various drugs. If it is AVP is administered in pharmacological doses, then it has a vasopressor action. So you can write it as a function, but you have to mention in high doses ADH. So that is why the name is vasopressin. So beta name is ADH, but it has in pharmacological doses or high doses. Pharmacological dose means the drug doses we are giving from administering from outside in pharmacological doses, or if sometimes ADH is very high in the body physiologically due to some reason or the other, then it can cause increase in blood pressure, but its normal function at physiological levels is not that function. So first you speak of antidiuresis and come one by one. Decreasing of renal medullary blood flow, influencing the anterior pituitary, all these things you mentioned. Glycogenolysis in the liver through V1A receptors, all these things things you mentioned, then only you can speak of the vasopressor action, but you mention that it is in high dose. Which is the action of which of the following actions of ADH is primarily or prominently noted when it is in given in high doses or in high amounts in the blood. So there will be so many actions, and then you mark this vasopressor action, right? Now oxytocin acts mainly on the uterus and breast. Okay. So what is the function of oxytocin? Primary function, not primary, both on the uterus and breast they are primary functions, but still we speak of the action of oxytocin on milk ejection first. Milk ejection reflex. It contracts the myoepithelial cells of the breast. It is not forming or secreting milk. It helps in the milk ejection reflex. If milk is not there in the breast, then there is nothing to eject. So, but it cannot form milk or secrete milk, just milk ejection. During suckling by the baby, the receptors are stimulated in the hypothalamus. Then more and more oxytocin precursors are secreted. Whatever is the process, precursors, then oxytocin coming from the anterior pituitary and helping in by contracting the myoepithelial cells, milk ejection. But it has also a small role in aiding. It cannot directly do that itself, in aiding formation and secretion of milk. Formation and secretion of milk, one of the hormones is prolactin. We will come to that. but it oxytocin can aid it to some extent, can help it to some extent, but it can't do it alone. So what it is doing primarily is in the milk ejection reflex by contracting the myoepithelial cells of the breast. Mainly it happens when primarily it happens when the baby is suckling, the mother's nipples, then only milk is ejected. But after a certain period of time, it becomes milk ejection reflex does not depend only on the baby's, this does not depend only when the suckling is taking place. At first, after, just in the postpartum period. What is the meaning of postpartum period? Postpartum is just after birth of the baby. Postpartum condition of the mother or postpartum period is in relation to the mother just after the birth of the baby. Not just only, it starts just after the birth of the baby. Usually it is up to 6 months after the child's birth. So in the postpartum period, it is, so at first it is that the baby is sucking and oxytocin are stimulated by other actions also, like genital stimulation also causes some oxytocin secretion. Genital stimulation during sexual intercourse or like that. So genital stimulation may also cause oxytocin stimulation and milk may come out of the breast. But that is not at the beginning. At the beginning, the baby must suck. After some days, it happens such that genital stimulation can also cause it. Okay. So then also milk can come out of the breast. So this is oxytocin's primary action is milk ejection reflex on the breast. On the uterus, similarly it causes contraction of the uterus. In the early phases of pregnancy, it can also contract, but the action is not too prominent. As pregnancy advances, this oxytocin's action on the contraction of uterus increases. So as it increases, and it is highest during labor. During labor you will read in obstetrics. So labor is when the onset of labor means now the delivery is imminent. So during labor, action of oxytocin is most prominent and uterus contraction will occur, the baby will come out. So oxytocin is a prominent action. So oxytocin is so useful here that we use oxytocin from outside. Okay, oxytocin is used in the induction of labor from outside. It is a very important drug in the induction of labor. If labor is not being induced properly, then oxytocin dose is increased to induce labor. So these are the two main actions. Okay, these are the two main actions. But oxytocin on the breast, one action, on the uterus, another action. But oxytocin can also help in the transport of sperms. These are other actions. So these two you write at first. Actions of oxytocin, physiological actions of oxytocin. Other actions are, it can help in the just after sexual intercourse, it can help in the transport of sperms in the female uterus. Female uterus is female, of course female, that means in the uterus. Uterus cannot be male. So uterus, just after intercourse, transport of sperms in the uterus by, but that time the oxytocin, that means in a non-pregnant uterus, oxytocin action is not very prominent, but still it can contract the uterus to some extent, and it helps in the transport of sperms. Okay, and it also helps in the transport of sperms in the male reproductive tract by contracting the smooth muscles of the vas deferens. So the action is contraction of smooth muscles. Action is contraction of smooth muscle. Also in the smooth muscles of vas deferens in the male. Reproductive physiology will be done separately. Okay, but just you understand the actions of oxytocin by now. It can contract the muscles of the smooth muscles of the vas deferens, transport of sperms towards the urethra in the male reproductive tract. Okay, and when it will contract the smooth muscles of vas deferens, seminal fluid will be added to the sperms and the transport will be smoother. Okay. And oxytocin, these are, so these you write later. First action is on the breast, milk ejection reflex, then second is uterus during labor, most prominent action during labor. In pregnancy, as pregnancy advances, oxytocins, the receptors of the uterus are getting more and more, that means oxytocin can act more well on the receptors as pregnancy advances. Then you come to transport of sperms, these functions, and oxytocin. Last you can mention oxytocin is also called the love hormone. Intimacy between mother and child, it increases the mother-child bonding, and also increases the mother-child bonding, and also it helps in this somewhat, to some extent, in some books it is written that during sexual intimacy, the feeling of sexual pleasure, oxytocin have some role. But these are not very important functions. So you have to write about the milk ejection reflex and action during labor, even if you don't write anything else. Those are the prominent actions. So these are the two hormones of the posterior pituitary. Why they are hormones of the posterior pituitary and hormones of the hypothalamus, you should be able to tell by now, because they are not coming from the hypothalamus to the pituitary by blood. They are leaving the pituitary by through blood. So that's why they are hormones of the posterior pituitary. Actions of vasopressin and oxytocin. Right. Now come to the anterior pituitary. Anterior pituitary, these are the hormones. In the third column, growth hormone will be done in a separate class next day. Okay, growth hormone is a bit physiology of growth, and growth hormone is a bit long. Growth hormone will be done in a separate class. We come to ACTH. ACTH is produced from a precursor called pro-opiomelanocortin. Pro-opiomelanocortin. Okay, just before that, just you know the names of the cells from where they are secreted. These are the cell types of the anterior pituitary. In the first column of this picture, somatotrophs secrete the growth hormone. See, they are maximum in number. 50% of the cells in the anterior pituitary, the secreting cells in the anterior pituitary are somatotrophs. Lactotrophs 10 to 30 written. Next, somatotrophs following that is maybe lactotrophs are gonadotrophs, corticotrophs, almost next in abundance. It varies because anterior pituitary has a particularly there are stem cells, some pluripotent stem cells in the pituitary. Stem cells is you have some concept of stem cells from erythropoiesis. You should have some BFU, CFU lineage stem cells. Some concept of stem cells. Some stem cells can lead to all lines. Some stem cells can lead to only one line. So in erythropoiesis, you must have done this. You must know this by now. At least you know that stem cells can reproduce new cells. So pituitary has some, anterior pituitary has some stem cells, pluripotent stem cells. So whenever in general, mostly are the somatotrophs, growth hormone. But whenever some other hormone is needed in more amounts, then the stem cells can produce new cells. So it can say produce new. Thyrotrophs are least. Here it is given only 5%. Thyrotrophs are least. But if TSH is needed more, the stem cells can produce some thyrotrophs. At that moment, it can increase some produce some thyrotrophs. Thyrotrophs are usually the least. Okay, you don't have to remember the percentages, just know that the somatotrophs are the most abundant, followed by the other three, and thyrotrophs are the least. But in times of need, this can be changed as the anterior pituitary has some stem cells. Okay, pluripotent stem cells, pluripotent. These terms are somewhat maybe difficult, but just know pluripotent stem cells are there and they can alter this ratio of the different types of secretory cells of the anterior pituitary. Now, obviously, ACTH is from corticotrophs, but in the corticotroph, first what is formed? It is pro-opiomelanocortin. Short form it is written POMC. POMC. Now, in the human, from pro-opiomelanocortin, two things are produced. I'm sorry. ACTH, beta LPH is also called lipotropin. ACTH is corticotropin, beta LPH is lipotropin, function is not known. There is a chemical other than ACTH It has been named lipotropin, but exact function is not known. Beta endorphin is an opioid peptide. Opioids you will read in pharmacology about opioids. Beta endorphin is an opioid, it is secreted in very small amounts in the human beings. In some mammals, beta endorphin is in large amounts. In some mammal means some mammals where so we'll read about the structure of the pituitary, basic structure of pituitary now. In some mammals, it is secreted in larger amounts. In human beings, beta endorphin is in small amounts. Beta LPA is secreted, but secreted means beta LPA is from pro-opiomelanocortin, but beta LPH is not very means it has its function is not known this function is not very prominent. So, and main is so H, but you should also know that these are produced. Now, before coming to the actions of ACTH, just so see that intermediate lobe is labeled. The pituitary has an anterior lobe or a posterior lobe. Anterior pituitary, posterior pituitary. There is in some mammals. In the humans, it is in adult humans, it is non-existent. It regresses. Intermediate lobe is not there. Intermediate lobe may be there, and anterior lobe has some. See, there are different pars tuberalis, pars distalis, pars intermedia is the intermediate lobe. Pars tubularis and pars distalis. Pars distalis is the main bulk of the anterior lobe. Okay, you will read about this in anatomy, of course. Pars distalis is the main bulk. Pars tubularis is there is something called the nudal stalk in the posterior pituitary. Posterior pituitary, median eminence, infundibular stem, and infundibular process. So this median eminence and the infundibular stem, infundibular process make up the nudal stalk of the pituitary. And this surrounding this nudal stalk is the pars tuberalis. This is a part of the anterior pituitary. Anterior, posterior we have divided for functional, for our understanding, but the structures are together. It is surrounding the nudal stalk. Okay, and the main bulk of the posterior pituitary, not there, I think it is pars nervosa, from where oxytocin and vasopressin are ultimately going into circulation. Pars nervosa, because it is mainly a nudal structure. Pars nervosa, median eminence, infundibular stem and process, and pars nervosa make up the posterior pituitary. Main part of the bulk of the posterior pituitary is pars nervosa. Likewise, main part of the anterior pituitary, main bulk is pars distalis, which is the distalmost part of the anterior pituitary. Pars tuberalis is surrounding the nudal stalk. Nudal stalk is formed by the median eminence and the infundibular stalk together. Median eminence is actually not it is the sac-like structure, but it is from where the posterior pituitary is starting, the proximal part. So we do not concentrate on anatomy so much, but just for mentioning the intermediate lobe, from the intermediate lobe in animals where the intermediate lobe is present, that POFC, corticotropin like intermediate lobe peptide. Okay, CLIP, corticotropin like, but this is only in animals where intermediate lobe has not regressed. In humans it regresses. Okay, and in those animals beta endorphins are secreted in more amount. Also in melanocyte stimulating hormone. Not in humans it is very less amounts. Alpha MSH, beta MSH, melanocyte stimulating hormone, and alpha form and a beta form. So these are less, these are not very prominent actions or very prominent. CLIP is absent because intermediate lobe is regressed. In human men are ACTH, beta LPH, but beta LPH action is not known. Now the actions of ACTH. ACTH, obviously it will stimulate the adrenal cortex. Adrenal cortex we will read later, adrenal gland, to secrete cortisol and sex steroids. Don't speak here. To some extent on aldosterone, but action of aldosterone and aldosterone is, there is some extent secretion of aldosterone. So adrenal cortex secretes glucocorticoids, cortisol, mineralocorticoids, main is aldosterone and sex steroids. ACTH's main function is to produce cortisol and sex steroids, not aldosterone. To very small extent on aldosterone, which we mentioned in ADH also, that ADH will form ACTH and ACTH will form aldosterone, but this is a very ACTHs, this is a very not the primary function of ACTH. Primary function, it influences to secrete glucocorticoids and sex steroids, and obviously like it will also help in the growth and maturation of the adrenal cortex cells. These two zones from where cortisol and aldosterone, mineralocorticoid, that zone ACTH has a minimal action, but these two zones from where cortisol, glucocorticoids and sex steroids are secreted, ACTH is in the growth and maturation also ACTH is helping. Okay. So this is the formation of the various chemicals from POMC. CLIP not in humans, beta endorphin to very small extent, gamma lipotropin also in for the intermediate low, where you don't have to remember, beta lipotropin, that means beta LPH in humans, but function is not known. So ACTH through the you don't have to go into the receptors too much. See, diverse physiological actions of cortisol, steroidogenesis, sex steroids, cortisol and steroidogenesis plus cell growth. The left hand. On the right hand, ACTH binds to the some receptors, you leave it, MC1 are, those are the receptors. It has action on the skin, melanocytes in skin for melanin synthesis. ACTH acts on the skin for melanin synthesis, pigmentation of the skin. In hypopituitarism, hypopituitary is not functioning properly, skin becomes pale. Okay, melanin synthesis, it is by ACTH. You don't have to concentrate on the whole diagram, it will become complex. ACTH, melanocytes in the skin for melanin synthesis and dispersal. In the fish, reptiles and amphibians, as there is alpha MSH, beta MSH, they can change their color for camouflaging. Some reptiles can camouflage. All those are dependent on MSH, which is not present or present in very small amount in humans. Here just melanocytes are being influenced by the ACTH and melanin is being synthesized and dispersed throughout the skin. If ACTH is not functioning properly, or ACTH or pituitary as a whole is not functioning, then there is pallor, abnormal pallor. So just remember this. TSH is very easy, functions of TSH. It will influence anything, thyroid function, total thyroid function is dependent on TSH. Thyroid hormones will not be produced if TSH is not there. It acts on the thyroid follicles. Thyroid hormone is a separate class, 2 classes will be needed, I think, thyroid hormone. It acts on the thyroid follicles to influence every aspect of thyroid hormone synthesis, storage, release, everything is dependent on ACTH. TSH, thyrotropin, TSH. And also growth of the thyroid epithelial cells, growth and maturation, hyperplasia, hypertrophy, these terms you will read in pathology. Hyperplasia means increase in number of cells, hypertrophy means increase in size of cells. All these are dependent on TSH. Thyroid epithelial cells, hypertrophy, hyperplasia and growth, everything, maturation dependent on TSH, production of thyroid hormones, synthesis, storage, release dependent on TSH. Functions are, these are the functions. Functions of TSH are simple enough. These are the functions. What are the that means wholly tropic action. ACTH, tropic action on adrenal gland, but also it influences the skin. TSH, everything on the thyroid gland, very straightforward functions. Next is FSH and LH. follicle stimulating hormone and luteinizing hormone, gonadotropins. So, and TSH as a half-life, say TSH, ACTH as a, if sometimes if there is any MCQ, half-life of ACTH is about 10 minutes, right? In case of TSH, it can be from several minutes to hours. ACTH is 10 minutes, half-life. Half-life, what is half-life you read in pharmacology? To reach the half of the plasma level from current time to reach the half of the plasma, that is called half-life something. Half-life of ACTH is 10 minutes. But in TSH, case of TSH, it's several minutes to hours. It can be several hours also, it varies. TSH half-life is, FSH is 3 hours. LH it's 1 hour. FSH, you can remember like FSH has 3 letters, it's 3 hours. LH it's 1 hour almost. Usually I think this should not be asked, but if it sometimes if you face some MCQs, you can tackle this. So I am telling it. Now, otherwise it is not required, half-lives and all. So functions of FSH, follicle stimulating hormone. In the males, it is straightforward function. It helps in spermatogenesis. Okay. LH helps in the males, helps in the, it is tropic to the Leydig cells. FSH is tropic to the Sertoli cells. Male reproductive system, female reproductive system will do in separate classes. FSH is stimulating the Sertoli cells and helping in spermatogenesis. It helps maintain the spermatogenic. Wherever it will help maintaining the anatomy, morphology of that, wherever in TSH also growth, maturation of thyroid follicles, thyroid epithelium and also the function. So, it helps maintain the spermatogenic epithelium and helps in spermatogenesis, and LH in the males, tropic to the Leydig cells, helps in the secretion of testosterone. In the females, FSH will, early growth of the ovarian follicles is stimulated by FSH. Ovarian follicles, early growth of ovarian follicles is stimulated by FSH, and final maturation is done by LH. So, functions of FSH, if it is you have to mention, in males, spermatogenesis, maintenance of spermatogenic epithelium and spermatogenesis. In females, early growth of ovarian follicle. LH in males, testosterone production, tropic to the Leydig cells, helps in testosterone production by the testis. In the females, final maturation of the ovarian follicle, and also it has direct role in ovulation. During the menstrual cycles, ovulation is more or less around the 14th day. There is something called the LH surge. We will learn when we do the reproductive system. LH surge. LH increases many times in plasma. Highest peak of LH secretion is during just before ovulation, and it induces ovulation. Okay, and if there is no fertilization, if the ovum is fertilized by the sperm, there is fertilization and pregnancy is ensuing. If there is no fertilization, something called the corpus luteum is formed, and from the corpus luteum, what hormone is secreted? Progesterone. This formation of corpus luteum and progesterone secretion is influenced by the LH. If there is no fertilization, okay, obviously in most of the cycles there will be no fertilization throughout the female reproductive system, female reproductive age say 18 to 45, mainly consider 18 to 45, how many years, or say 15 to 45, 30 years, 12 months, 360 cycles, both ovaries considering double it, but only once or twice or thrice ovum will be fertilized by sperm. In all cases where it is not fertilized, corpus luteum will be formed and progesterone will be formed from it. Female reproductive cycle will be system will be discussed. We will know all these things. So, this formation of corpus luteum and secretion of progesterone from it is influenced by the luteinizing hormone. Okay, next is prolactin, which is not tropic. Prolactin is not tropic. Prolactin is from lactotrophs, also called mammotrophs. Prolactin, lactotrophs are also called mammotrophs. So, prolactin after estrogen, and prolactin half-life is 20 minutes and you can just write down its normal plasma level also. It's around 6, it varies, it is around say 6 to 50, varies between 6 to 50 nanograms per milliliter, ng, nanogram, 6 to 50 nanograms per ml. half-lives, plasma levels is not very important, I think, but sometimes it may help you to tackle some extraordinary MCQs formed by extraordinary minds. Bad people like me, if they form MCQs, then they can form these MCQs, plasma levels such and such, don't need to remember as such, it should not be asked. But 6 to 50 nanogram per ml, prolactin half-life is just somewhat double of ACTH, you can remember like that, it's 20 minutes. So prolactin after estrogen and progesterone acts on the mammary glands, mammary ducts. Prolactin helps in the differentiation of lobular, alveoli, lobular alveoli. So this differentiation is dependent on estrogen and progesterone, of course, and then it is done by prolactin. This is the main action. And in production of milk as such, prolactin has minimal action. Direct production of milk, although the name is prolactin, it has minimal action. It is not needed to that extent. So which hormones are mainly required for milk production? It is the growth hormone and also the thyroid hormones, not the TSH, thyroid hormones, T3, T4. Thyroid hormone, growth hormone and thyroid hormone mainly does the influences bulk of the milk production, aided by prolactin and also hormones from the adrenal cortex. Okay, corticosteroids, hormones from the adrenal cortex. But prolactin as corticosteroids have minimal action on milk production. Direct milk production, although prolactin we are mentioning it is helping in milk synthesis and production, that means milk synthesis, but direct synthesis is more influenced by growth hormone and thyroid. So what is the action of prolactin? It is helping the anatomical differentiation of those mammary glands primed. Primed means already estrogen, primed means already some hormone has acted there. Priming. Primed by estrogen and progesterone, now prolactin is helping in the differentiation of the lobular alveoli. This is the action of prolactin. And then it has a minimal action or it has little action in direct milk production also, but main action is by growth. If growth hormone and thyroid hormones are deficient, prolactin alone can do little. It cannot do much. Okay. So this is the action of prolactin, and after pregnancy, just after pregnancy, prolactin also helps in forming lactose. Okay, by galactosyl it forming lactose. In the males, function of prolactin is very, another important function is in postpartum phase, prolactin can decrease the formation of gonadotropids, FSH and LH from the pituitary. And so cycles, postpartum cycles come later, and even if the cycles are cycles come back, menstrual cycles, they are anovulatory. Ovum will not be formed, anovulatory cycles. So prolactin somewhat helps in natural contraception. That means sexual intercourse in this postpartum phase without any contraceptive aids won't result in another pregnancy. So prolactin helps in natural contraception. Prolactin is influencing anovulatory cycles because it is decreasing the secretion of gonadotropins from the ovary. In males, prolactin function is almost, there is no function in males. Prolactin is there to some extent, but there is no function. Some authors are writing in high if prolactin, there are tumors, pituitary tumors secreting prolactin high amounts, there may be erectile dysfunction in males. This is in high amounts, prolactin, pituitary tumors secreting prolactin secreting tumors. But as such, physiologically, there is no action of prolactin, although there it may be present to some extent, it has no action is known till date. Okay, growth hormone will be done in the next class separately. These are the other anterior pituitary and posterior pituitary hormones. Hormones on the posterior pituitary and effects of pituitary growth hormone and effects of pituitary insufficiency, another class.
We'll start very pertaining subject today. Blood glucose homeostasis means maintenance or regulation of blood glucose level. Throughout our day, a blood glucose level is maintained within a range. Below that range, we call it hypoglycemia. Above that range, we call it hyperglycemia. Which one is not? Which one is more dangerous? Hyperglycemia or hypoglycemia? Hypoglycemia. Which one is more prevalent? Hyperglycemia or hypoglycemia? Huh? Hyperglycemia. Who shows more frequent hypoglycemic events? A diabetic person or a non-diabetic person? Diabetic person. Very good. So, there are different levels. When you ask that what is the normal level of blood glucose level, then we must attach few conditions with that. What are the conditions? In which metabolic state we are measuring the blood glucose level, that should be mentioned. Right? So, there are 4 stages where we measure blood glucose level. Number 1 is fasting. Number 2 is postprandial. Number 3 is random. And number 4 is starvation. Correct? Starvation. Fine. Now, what is the normal level of blood glucose level in fasting condition? Now, this is the number which you used to follow till few years back. Okay. Even if you tell these numbers today, we will not put cross, we will accept it. But there is an association called American Diabetic Association, the American Diabetes Association. These association, they rule the world. Whatever rules, regulations they set up, we have to follow. Okay. Unless we have our own association, strong enough to counter the other. Now, according to this, see 6 to 12 hour fasting meals. 6 to 12 hour meals, when 6 and when 12. If a person comes to you, general proposition, then you say overnight, right? So, what do you mean by overnight fasting? How many hours? 8 hours. Correct? A person takes dinner at 10 o'clock and comes at you at 12 o'clock for fasting. Can you take the fasting? If he comes at 8 o'clock, can you take the fasting? If he comes at morning, 4 o'clock, what? Yes or no? Can we take or not? Huh? 4 পর নিতে পারবো? Remember what I mentioned, if a person comes to you, suppose a person is unable to come to you, he is in non-ambulatory state, means he is occupying a bed in the nursing home or a hospital, correct? He is not able to move and he is under parenteral nutrition. Then, parenteral nutrition means through pipeline, IV, he has been given food. So, you can switch it off on our, on whatever we want, whenever we want. In that case, it is 6 hours, any time a day. Otherwise, it should be at least 8 hours overnight. Morning, 6 o'clock you have breakfast or 8 o'clock you have breakfast, and evening, say around after 8 hours, say after 5 o'clock, can you give fasting? Unless you are under parenteral nutrition. Okay. when a patient is coming to you, it is always better to take overnight fasting at least 8 hours, not exceeding 12 hours. Not exceeding 12 hours. Correct? Then it will not be fasting anymore. Clear? 8 hours minimum overnight and 12 hours maximum, not beyond 12 hours. If a person is under parental nutrition, then 6 hours gap, because he is not working out, he is not exercising, he is not walking, he is not going anywhere. So that we can consider as fasting. Any time of the day, it may be noon 12 o'clock to evening 6 o'clock, 6 hours fasting. If the person is under parental nutrition. Am I clear? Right? Now, see, after 1 hour, you forget that one. After 2 hours, see, this values should be same. Values should be same. Wherever we started, the graph should come down to the same level. It might go a little below than the normal level. That is also normal. It might be little above than the normal fasting level. That also normal. But in each case, see, beside one number is written 126. What is that? According to ADA, up to 100 means 99.9. We consider normal level for fasting. The moment it becomes 100, it is no more normal level for fasting. It falls under a new category called pre-diabetic zone. 100 to 126, it becomes pre-diabetic zone. More than 126 in fasting, it becomes diabetes. More than 126 becomes diabetic. But this is not the only criteria for diagnosis of diabetes. When diabetes will be taught in detail, then you will come to know. At least 3 times it should exceed 126 after the regulation of diet and change in the lifestyle before starting medication. Correct? Anyway, so fasting should be taken overnight, 8 to 12 hours, 6 hours any time for parental nutrition. It should be below 100, 70 to 100, below 100, 70 to below 100, normal. If you write 110, no issues, we will give marks. But remember the actual values. It must not cross 126 in either case of 2-hour postprandial or fasting. Correct? Now, in fasting, you might have seen values, say up to 150 we can take. When the fasting is below 126, in that case we can consider PP up to 150 or 160, up to 150 or 160 in postprandial, 2-hour postprandial. We can consider to be normal. Getting complicated a little bit? It is. So, fasting, when fasting is below 126, we can consider is non-diabetic if the PP is up to 160. But when the fasting is beyond 126, it will never be within 160 in 2-hour postprandial if the person is diabetic and not under medication. If the person is under medication, then it might go below 100 in postprandial. There are different stages of diabetes. Those stages are yet to come for you. So, for the time being, you remember this should be similar to postprandial. Up to 160 you can write, we will give marks. Clear? 70 to 160. But it must not cross at any moment 180. Why? That is a renal threshold for blood glucose level. What do you mean by renal threshold? The concentration of a substance in the blood beyond which it appears in urine. ব্লাডের মধ্যে কোনো প্যারামিটারের কনসেন্ট্রেশন যা ক্রস করলে সেটা ইউরিনে অ্যাপিয়ার করে তাকে আমরা বলি রেনাল থ্রেশহোল্ড। বিভিন্ন কম্পাউন্ড রেনাল থ্রেশহোল্ড বিভিন্ন হয়। গ্লুকোজের ক্ষেত্রে মোটামুটি ফিক্সড হচ্ছে 180। এটা ইন্ডিভিজুয়াল নেফ্রনের জন্য নয়, ওভারঅল কিডনির জন্য। ইন্ডিভিজুয়াল নেফ্রনস মে ভ্যারি ইন দ্য রেনাল থ্রেশহোল্ড। It is average for whole kidney. Now, when we call the person is under starvation, it is below 70. It is below 70. But it must not go below 60. Now, can anybody tell me what condition is missing here? Number one, whether the person is under parental nutrition or not, that is missing, is not mentioned in this chart. And what is that? Another important, very important thing. The age of the patient. Remember, gender has nothing to do with this problem, but age. The person should be 18 years or more to follow these results. If the person is minor, then these results is not for them. Am I clear? A 10-year-old kid will show normally less than 70. That doesn't mean he is hypoglycemic. It is normal for it. Clear? কি হলো? আরে কোন দিকে যাচ্ছে? Correct. So what are the effects of hypoglycemia? Quickly go through. So if hypoglycemia occurs, there is one organ which is affected, that is brain. It leaves solely on glucose. In absence of glucose, it cannot function. It shuts down. মজার ব্যাপার হচ্ছে, the funniest thing is the symptoms of hyperglycemic and hypoglycemic shock is similar. Symptom wise, similar. You cannot make out by seeing whether the person is having hypoglycemia or hyperglycemia. Correct? Sudden hypoglycemia below 40 milligram per deciliter lead to coma or even death if not countered properly. Time is the best, is your enemy here. Now, to maintain this blood glucose level, we have to rely on hormones. Correct? Different hormones. So first you name all the hyperglycemic hormones. Shall we write hyperglycemic hormones? Yes, I got this. Next. Huh? Next. Correct? Plenty. Whereas hypoglycemic was only that's why in an olden book a picture is to be given where all the animals are participating in a tug of war. In one side there is an elephant written insulin on it, and the other side deer, giraffe, zebra, everyone is lion, everyone is pulling. No. So only one hypoglycemic hormone, insulin. Now here this question has two ways to answer. First, you must mention the normal levels, then you must mention the name of the hormones, and then hormone wise you can go, mentioning the effect of each and every hormone. Now see, if you have to finish this list of hormones in examination hall by writing, then you have to have a like this speed, correct? That is not possible. So this is another way to answer this question. We consider this answer in 4 groups, 4 metabolic conditions. We will consider the blood glucose level under 4 metabolic conditions. Number 1, well-fed state. Number 2, fasting. Number 3, starvation. And number 4, which is not a physiological state, rather a pathological state called diabetes mellitus. So there are 4 metabolic states. Now the 4th one is a pathological condition, but rest 3 are physiological. So we will start with the first one. We will start with the first one. What is that? Well-fed state, number 1. So you first have to write what do you mean by well-fed state. What do you mean by well-fed state? Anyone? Try. I will give the correct answer, don't worry, you just try. Well-fed state bolte ki bojo? Huh? After meal. চিন্তা করো একটুখানি, খুব কঠিন নয়। Anyone? বলো। আস্তে আস্তে বল, দাঁড়িয়ে বল। গুড, এটা খুব ভালো আনসার, ভালো আনসার। কিন্তু আনসার এরকম হওয়া উচিত, স্টেটটা যখন আমি বলছি ইউ শুড মেনশন দ্য টাইম, ডিউরেশন অফ টাইম, ডিউরেশন অফ টাইম। আমি যদি ফাস্টিং ডিউরেশন টাইম বললাম, টাইম, তাহলে ওয়েল-ফেড স্টেট মানে হচ্ছে আমরা হাউ মেনি টাইমস ডু উই টেক মিল, how 4 times we take meals a day. So morning, suppose 8 o'clock we take breakfast, afternoon say around 1 o'clock we take lunch, and then 5 o'clock we take snacks, and then 9 o'clock we take dinner. So 10 to 8 again it becomes 10 hours, 10 hours. So that 10 hours, within that 10 hour, we consider the first 6 hours where we utilize the glycogen, and next 4 hours we survive on gluconeogenesis. Correct? A well-fed state is considered that where we take sufficient amount of food in 4 times a day. so that the duration must not exceed 6 hours or more. 4 times a day, and it should be sufficient. Suppose you are taking 4 times a diet, 4 times a meal, but every time you are taking only 2 pieces of biscuits. Is it sufficient? No. So you must take adequate amount of food 4 times a day. That is called adequate amount of food. 4 times a day, that is called well-fed state. If you are under this state, then your body muscle synthesis will take place, your lipogenesis will take place. You will be under a positive or anabolic effect. Every time you take meal, the insulin secretion will increase, and under the effect of insulin, the anabolic effects will take place in your body. That is synthesis of muscle proteins, synthesis of lipid, synthesis of glucose, glycogen, etc., etc. Correct? So in the well-fed state, we write the answer like this. In well-fed state, increases. Do you agree? Soon after we take the food, glucose level starts increasing. This will trigger the secretion of insulin. Now, presence of insulin will trigger several metabolic pathways which will utilize glucose. Presence of insulin will trigger several metabolic pathways which will utilize glucose. What are those? Correct? Do you agree? Lipogenesis, protein synthesis and increased lipogenesis. So what will happen? The blood glucose level will come back to normal. Will bring the blood glucose level down to normal range. When it will try to shoot up after taking food. Clear? Now we come to the second condition is fasting. Blood glucose level not decreases but tends to decrease. It tries to go down. Tends to decrease. It tries to go down below. Insulin secretion gradually slows down. It does not stop permanently, but slows down. Glucagon secretion rather starts increasing. The ratio between the comparative concentration of glucagon and insulin, this ratio is sensed by the cell. The moment cells sense that the glucagon is to insulin ratio is increasing, it starts giving the reverse signal. Insulin is an anabolic hormone. So in absence of insulin, there is no anabolic reactions. That means no synthesis. Correct? Breakdown will not take place now, but there will be decreased protein synthesis. It is yet to start ketosis, but there will be decreased decreased lipogenesis. And as a effect, fine. Remember, when we are considering insulin and glucagon, these arrows are exactly opposite. But these opposite arrows are not fit for any other two hormones with insulin. Say, all the arrows will not be exactly opposite with insulin with that of the epinephrine or norepinephrine or cortisol or growth hormone. Some or other will be different. But only with insulin and glucagon, all the arrows blindfoldedly you can reverse. That's why I would suggest you not to go with hormone-wise approach, rather metabolic state-wise approach to understand it better. Correct? Some books might have given you hormone-wise approach, and that you will study, but it is very difficult to remember at the time of examination, and that part is mostly asked in the physiology part, effect of such and such hormone. But here we are not working on that. We are working on why and how this effect is brought about, that we are worried about. We are not worried about what are the effects. Now, lipogenesis done. Next thing is starvation. When fasting continues for more than 48 hours, when fasting continues more than 48 hours, then what happens? We call it a starvation state. We call it a starvation. Now you can say, what is the name of the state between 24 to 48? Huh? I don't know. Whatever it may be. I don't know. I did not give the name. I don't know. Whatever they have been given, I am just telling you that. What is not given, I am not giving you. Up to you. Between 24 to 48 is unnamed, is not named. You can say prolonged starvation, you can say pre-starvation, both way. But after 48 hours only, starvation mode implies. We have to just blood glucose level is completely decreased. It is no more tends to decrease. Decreased. Glucagon level will be high, definitely, no issues. What will be lost there? This will be good, this will be good. There is no question of glycogenolysis. Why? Because after 4 hours, there is no question of glycogen. So these two lines will vanish. Correct? Rather, gluconeogenesis will come. Decreased protein synthesis will take place along with decreased lipogenesis will take place along with And before this comes, now these three are interrelated. Absence of insulin will trigger this one. Okay? Absence of insulin. Presence of glucagon will trigger this one. And effect will be due to this effect, right? Insulin will prevent, glucagon will trigger ketogenesis. Blood glucose level it can no more reach the normal level. It is below normal. Correct? It is always below 70. Always. Always below 70. Now, the fourth stage, usually we do not mention here. This is asked in final year in the subject of medicine. Because the moment you say this is a pathological condition, it demands medication. It demands medication. So, the medicine department will teach you what are the medications should be given the diabetic patient in order to bring back it to normal. For the namesake, if you want to know what are the metabolic changes occurs in nutshell during diabetes mellitus, I can mention. For diabetes mellitus in pathological condition, the blood glucose level highly increased. Glucagon secretion that is why diabetes. No insulin. Glucose is always there, so glucagon is not required. No insulin. The problem is if insulin was there, then it would have increased the rate of this, increased the rate of this, and this, decrease the rate of this. This one, insulin nahi to. Correct? Huh? Ketogenesis. Ketogenesis, increase in ketogenesis means increment in ketone body generation. But remember, we have another pair of organ called kidneys, which are very efficient organs. They can get rid of ketone bodies as well. So, even if we produce a lot of ketone body in our body, it is usually excreted. When the production level surplus the excretion level, then only ketosis takes place. So, likewise, so I mentioned for glucose, the renal threshold for glucose is 180 milligram per deciliter. Is there any renal threshold for ketone body? No. There is no fixed renal threshold like glucose in case of ketone body. It varies from person to person. A person may excrete at say 10 millimoles per liter concentration of ketone body through urine. A person may not excrete even if it is 22 millimoles per liter ketone bodies in the blood. And remarkably, the diabetic people show rather more retention of ketone bodies than a non-diabetic patient. Correct? The renal threshold for chronic diabetic patient actually increases. Even though it is 240, 260 blood glucose level, the glucose may not appear in urine. Because of the prolonged stay in that diabetic state, the renal threshold slowly increases. Anyway, so blood glucose level fails to reach normal. Now here we bring oral hypoglycemic drugs, glycosuric drugs, human administered insulin, artificially produced insulin. So all these therapies will bring back the blood glucose to normal level. See, this is the effect of insulin. Effect of insulin already given. Effect of glucagon on adrenaline. See, almost same, but not noradrenaline. In both cases, increased glycogenolysis, increased gluconeogenesis, increased lipolysis, oxidation decreases, glycogenesis decreases, lipogenesis decreases, glucose uptake decreases. Glucose uptake decreases means, anyone? Anyone? What do you mean glucose uptake decreases? Uptake by whom? Skeletal muscle and adipose tissue, which rely on insulin for glucose uptake, not all cells. What are the effects of glucocorticoids and growth hormone? Right? Growth hormone usually promotes protein synthesis, lipid synthesis, so that body can grow. So, see, glucose level will tend to, they will try to increase glucose level at the cost of lipolysis. Means they will trigger lipolysis, the person will become thin, but will grow in height. Correct? See, it is different from insulin and glucagon. Thyroid hormones. Again, this has negative impact on lipogenesis. A hyperthyroid patient will be thin, hypothyroid patient will be obese. That is the first sign we get. Now, this is a master chart. খুব সহজ মনে রাখা। Glycogenolysis, gluconeogenesis, blocks glucose uptake, blood glucose level decreases or increases, lipolysis, blood free fatty acid, proteolysis, blood amino acid. Blood amino acid means effect of proteolysis. If proteolysis is more, then blood amino acid will increase. If proteolysis is less, then blood amino acid will be decreased. If not, no effect, N. Correct? So first we come see what are the hormones? Insulin, glucagon, epinephrine, growth hormone and cortisol. So what are the effects of these hormones on glycogenolysis? Insulin decreases, rest all increases except cortisol. See, only you see insulin glucagon is just opposite. Rest all will vary at some other point. Glycogenolysis decreased by insulin, increased by all except cortisol. Gluconeogenesis decreased by insulin, increased by all. Blood glucose uptake normal means no effect. This moment no effect. Y means yes, it is affected. Epinephrine, growth hormone and cortisol. Blood glucose level decreases and increases by all. Lipolysis decreases by insulin, increases by all. Free fatty acid means lipolysis, effect of free fatty lipolysis is release of free fatty acid in the bloodstream. So bloodstream will increase in all, decrease in case of insulin. Proteolysis will decrease in case of insulin, increase in case of cortisol, no effect almost. Blood amino acid, D means decrease, I means increase, N means no effect. N and D means usually normal or slightly decreases. Usually no effect or slightly decreases, like this. Okay. So these are the different approach of answering this question. I leave it to you how you do that. All that I taught on the board, now it is here. Just go through. Yeah. Whatever I told, it is in here. Just go through, if you have a recap, and if you have missed some points, you can write it down. Correct? Remember, this part I have not mentioned. This part in the next class it will be taught, diabetes mellitus. Correct? Now, glucosuria. Quickly, I have 5 minutes I will take for this glucosuria part. This comes as a short note very often, glucosuria. What is that? Excretion of glucose or appearance of glucose in the urine. Appearance of glucose in the urine. What is, should we write glycosuria or glucosuria? Glycosuria or glucosuria? Huh? If we identify the sugar to be glucose, then it is glucosuria. If we do not identify the sugar as glucose, correct? If we perform GOD-POD, glucose oxidase method or hexokinase method with urine for identification of the glucose, then it is glucosuria. If we perform Benedict test, then it is glycosuria, because there are many other reducing substances other than glucose. Correct? So how much? Normally 150 milligram per day, less than 150 milligram per day, we excrete. Causes. Quickly write down. Few of the causes are still unknown to you because amino acid metabolism is not done. Anyway, let us discuss what is diabetes mellitus glucosuria. That means simply overload glucose. Blood is overloaded with glucose, so it appears. Which is beyond 180 milligram %. That's why it is appearing in the urine. Next, adrenaline glucosuria, adrenaline surge. When you are watching nail-biting finish cricket match or football match, exciting football match between Brazil and Argentina, suppose, then what happens? Your adrenaline surge is increases, levels. So that increases blood glucose level. And if you stay for a long period in that excited state, then what will happen? The glucose may appear in urine due to elevation of blood glucose level beyond 180 milligram per deciliter. Elementary glycosuria, it is, এই causeগুলো বলে দিই, adrenal glycosuria কি হয়? একটা হচ্ছে pheochromocytoma. What is pheochromocytoma? That is a tumor, basically a tumor which produces catecholamines. A condition called as ectopic production of catecholamines. Ectopic production of catecholamines. Tumors other than the adrenal glands which starts producing catecholamines, means epinephrine, norepinephrine, all these hormones. There are 3 hormones: dopamine, epinephrine, and norepinephrine. These 3 are together called catecholamines. So secretion, increased secretion of these due to tumor formation in other part of the body other than adrenal gland will lead to this condition called pheochromocytoma. Emotions, correct? When you are watching Jawan, Pathan, what else? donkey. I don't get any other names of movies, you know, except Shah Rukh Khan movies. That is my incapability. Anyway, stress. See what is written. Test it. When you face oral examination, find it. It is right. Correct. So, suppose he is facing me in oral table. What will happen? The first thing, his adrenaline will shoot up. Hypotension. When pressure falls, blood pressure. Injection. What does injection means? How many of you are there who are scared of injection? Raise your hand. There is no one. Acha, how many of you got fainted in the first hematology practical in physiology? হয়নি পিকিং হয়নি এখনো ব্লাড টেস্ট হয়নি হেমাটোলজি তো কে ফেইন্ট হয়েছে বল দেখি তুই হচ্ছিস নাকি ও সেই জন্যই বলছে না কে ফেইন্ট হয়েছে বল কে অজ্ঞান হয়েছে হাত বলে দে তুই হাত তুলছে না সব লজ্জা চোটে ওটা হয় ফোটাতে যাবে টেনশন বাড়ে তাই না তারপরে প্রথমবার যখন ক্যাডাভার দেখা হয় তখন কি হয় প্রথমে ঢুকে বোঝা যায় না কোথায় বডি কোথায় মানে ক্যাডাভারতে তখন আমার মাথায় তখন হচ্ছে বডি লাশ কোথায় এখন দাদু ঠাকুমার লাশ দেখে অভ্যস্ত ওই লাশের সঙ্গে ক্যাডাভারের কোনো মিল নেই খুঁজে বেড়ান তাও দেখলো যে টেবিলে হাতে দাঁড়িয়ে আছে একটা পুতুল রাখা আছে কেউ বলে ক্যাডাভারের পাশে হাত দেবে না স্যার বললেন হ্যাঁ তাই না এ হয়নি কারো হয়নি এই ব্যাচে বাবা তাহলে খুব স্ট্রং ব্যাচ বলতে হবে খুব রেয়ার তাও তাই না সো এলিভেটিক গ্লাইকোসুরিয়া so it is due to intake of large amount of glucose after prolonged carbohydrate deprivation তাই না for 2 days you have been not eating any food and then you reach your mama bari and mamima gives you a plate full of biryani what will happen you will fall sick due to তাই না renal glycosuria nothing to do with the glucose metabolism your kidney disorder purely kidney disorder congenital pregnancy induced just remember these names point congenital pregnancy induced nephritis or nephrosis and florizin induced florizin is a drug which induces renal glycosuria it blocks the renal reabsorption of glucose from PCT. All right, pregnancy usually induce glycosuria or glucosuria. Diabetes in a sense, benign glucosuria, renal diabetes. Blood glucose is normal, well within the normal range, 130, 140. But urine is showing +2 glucose. Why? Because the kidney is compromised, renal disease. It is due to insufficiency of renal function. Nothing to do with the insulin level.
We call them as glandular tissue. So today we are going to learn the general features of these glandular tissues. Then we can move to identify different types of glands which are present in our body and understand this particular different histological anatomies. So whenever its gland is given, so if you are just like a defining which is a part of this organ or tissue which is capable of producing some kind of secretions. That secretions could be like the hormones, it could be enzymes, it could be proteins, etc., etc. They are of different functions, maybe producing some kind of like a chemical changes, maybe just like a breaking down some proteins or any kind of substance which is glucose or fats or anything like that, or maybe just like producing some elements which is doing some physiological work like lubrication, etc., etc. So depending on this particular elements, we have to understand this particular glands, which is the basic framework. That's what we are going to learn. So, wherever you are going to see these particular glands, so it consists of few things. It consists of the cells. Now, the cells which is present in a gland, whichever the glands you are addressing or whatever the glands you are talking about, these glands are made of cells which are producing the secretions. That means we call these particular cells which is producing secretions, we call them as secretory unit. Now, these secretory units may be of different shape and size. They may be looking like circular, they may be looking like a flat shaped or tall or columnar kind of looking cells. It depends on the different shapes. We call them as together secretory units. Sometimes we address this particular secreted unit as acini. So, acini, the word we may be using frequently if that particular secretory unit, which means the cells, looking like little bit tall and flask shaped and little bit dilated, flask shaped vase. You know the flower vase, if it is looking like flower vase shaped, we call them as acini, right. So, the acini is synonymous or can be a replaceable term with this secretory unit in terms of the glands. Majority of these particular glands are of this particular flask shaped or vase shaped. So, this particular entity we use this word. So, the secretory unit is there. That means we have the cells which is producing the secretions. Now, if you have this particular cells which is producing the secretions, to pump out the secretions, we need some kind of muscle powers. So, we need some kind of cells that are capable of contractile nature. We call this particular cells which is capable of contractile nature, we call them as myoepithelial cells. That means these particular cells have got pretty much of actin, myosin filaments are filled in it, and they itself, the cellular unit works like muscles. So, we call them as myoepithelial cells. So, this composed of together the secretory unit, which means the secretory cells and the myoepithelial cells. So, if you have this particular glands, if a cross section looks like this and this particular glands have got a architecture like this, cells are oriented like this, and this is the central duct or lumen if it is exocrine gland, and this particular gland is having this kind of cells which is placed in it and a nucleus over there. There are some cells has to be there around this particular element here or here, placed as special cells which is capable of producing some kind of secretions, pumping actions. We call them as myoepithelial cells. The dark color, the black one are that kind of flat cells which are contractile cells. So, if the contractions are not there, the fluids which is secreted by this are not going to be poured into the duct system and it is not going to be come out. So, we need some kind of pumping actions inside to it, the cells is there, but we do not have the muscles or fleshes in there. So, we need some kind of cellular modified elements, we call them as myoepithelial cells. So, this is in short about this particular cellular architecture which is present in terms of the glands are concerned, right. Now, once we have these particular glands, we have to classify the glands. There may be, we have to just like streamline it. There may be just like a different varied form of the glands are there. So, we have to streamline it so that we can memorize these different types or different subdivisions and understand the functions. So, one of these divisions is very easy for us to understand, that either they have the glands with the ducts or not having ducts, which is the easiest form of classification. We call them as with ducts, we call them as exocrine glands, and without ducts, we call them as endocrine glands. Now, this particular phenomenon of exocrine and endocrine phenomenon is that they have the ducts or not, they are kind of things. So, these particular glands are developed from the surface cells, we call them as epithelium. We are learning the development of, we learn the 3 germ layers, ectoderm, mesoderm, endoderm, 3 layers of that. So, the ectoderms are producing these particular glands. So, these particular glands are produced by the surface cells, we call them as ectoderms. Say for example, this is some of the cells go down and make a cluster of cells like this. We call them as this gland, which is invaginations of this ectoderm or surface epiderm. So from the surface, the glands develop from here and buries deep into this particular skin and creates this particular gland. Now, if this connections, which is lying with this ectoderm, with these connections with this particular gland is present, that remains as a duct. And if it loses the connections from this particular ectoderm, it becomes this particular gland, which is known as the endocrine glands. So some of this particular gland loses the surface connections, which was initially it is coming from, and buries deep into the tissues. They become a gland which is known as the endocrine glands, which is not having any glands. And if the connections are present, which is remains as the duct, then we call them as exocrine glands. Simple, right? Now, other than this exocrine and endocrine, we have a gland which is having a functional nature. Additionally, we call them as paracrine glands, right? We heard about that particular gland as well. So there are some cells which is from this particular glands is secreting and affecting this particular same neighbor cells which is around to it. So we call them as paracrine glands. So there are three basic classifications of the functional parts of the glands is concerned: exocrine gland, endocrine gland, and paracrine glands. These are the easiest form of classifications. Now, other than this, we can classify this particular gland based on this particular gland, which is exocrine gland. We can classify it based on how this particular gland's cells are composed of. There are three different types of the cells we commonly see these particular glands are there. We call them as a holocrine gland, we call them as merocrine gland, we call them as apocrine gland. There are three basic classifications there. Holocrine gland is a part of the gland which is the entire gland or cells which is present within this gland dies out if the gland secretions are over. Apocrine gland is a kind of gland where the cells which is present, which is apical part of the cell of the gland, is shed off. And merocrine gland, where this particular exocrine nature of this particular or expulsions of this particular secretions are coming in terms of exocytosis. So if this particular secretions are coming with this breakage of the cell, or if it is coming with the exocytosis or destructions of the cells, we can classify it based on that particular element. We call them as apocrine gland or apocrine cells which is there, which is called a merocrine gland, which is another classification, and holocrine. So these are the three another form of classifying these exocrine glands are there. Now, other classification that can be done. How this particular nature of the secretions that is coming out of this particular gland, we can call them based on the nature of the secretion. Say for example, this particular gland which is present over here creating or producing some kind of fluid, we call them as glandular secretions. So this particular glandular secretions which is coming over here, we analyze the chemical nature of it. So if this particular chemical nature or this particular fluid which is coming out turns out to be protein rich and the fluidy in nature, that means it's thin, we call this as a serous secretion. So we call this particular gland as serous gland. Now if this particular glandular secretions are sticky and high amount, if this particular like a mucin element is there, we call them as mucinous gland. And if it is a mixture of that, we call them as mixed kind of that. So we call this particular gland based on secretions, we call them as serous gland, mucinous gland, and mixed kind of gland. So the secretory nature of this particular gland also helps us to classify this particular secretion nature over there. Largely, whenever we are going to address this particular anatomical entity, we just like a judge into this particular natures of this gland which is coming out. What are the nature of this particular fluid that is coming out of this particular gland, whether it is watery in nature, whether it has this particular mucin which is thick in nature, or this particular thing has a mixture of this. So for example, we will be talking about this particular secretion which is coming from the salivary gland. Now we have this particular salivary gland present around this particular mouth, which is principally responsible for lubricating the fluid material and as well as breaking down some kind of food particles which you are receiving in it. Now this particular glands, the large gland we have this around this particular face, we call them as parotid gland, right? So parotid gland secretions, which is coming out of here, which is serous in nature. That means it's a kind of like high end of the fluid which is coming over here, which is protein rich fluid, right? This is one of the example. Other things, sublingual, submandibular, etc. glands are there. So the nature of the secretions, if it is there, which will be just like based on this particular, the nature of the gland divisions can be done. Now compared to this, you can see that this particular glands which are, we are saying that exocrine glands. Now this particular exocrine glands, if the nature of the fluid, depending on it receives the caliber of the duct. So if you have a serous secreting gland which is the secretions of which is watery in nature compared to this particular mucus containing gland which is secreting the mucus rich fluid which is thick. So do you think this caliber of this particular duct which is present in here are going to be same? So do we need this particular caliber to be different in case of this particular serous gland or mucinous gland, or are going to be same? It might be different, right? So what is the logic of being or making it different? If the serous is there, it is more fluid, that means it is easy to flow through, and if it is mucinous, that means it is a sticky thing, that means it is running slow. So that's why the caliber of this particular ducts has to be different. So caliber means the lumen through which the fluid is coming. So whenever you are seeing this particular gland, if it is you are known to it, you have to look into the caliber or the thickness or this lumen depth as well. So in case of the serous, the lumen is short. In case of this particular mucinous, the lumen is wider. So we get this particular lumen different in case of this particular nature of the fluid. Reasonably so, with the logic you can see water and some kind of sticky material, if it is coming, it needs like a more and more lumen compared to the water fluid. So based on this as well, we can have a rough idea what kind of secretions that particular gland is producing. All right. So these are the different morphological classification that can be made. And other classifications we can be made, we can just like do it like that, the number of the cells which this particular gland has. So if it is a single cellular or if it is a multicellular, that means if the gland is composed of one cell only or multiple cell. The classical example of one cell gland is that particular gland, we call them as goblet cell, which is a misnomer. The goblet cell which looks like a flask. So this particular goblet cell we are going to see in very shortly. It looks like a flask which is acini pattern, as I am saying, is single cell unit which is a exocrine gland which is expelling out the fluid within this particular broader lumen, and this particular only one cell is composed of the gland itself. So we call them as unicellular gland, which is the goblet cell, but we call them as a cell because it's a one cell, but this is basically itself in one man army. It's producing tons of kind of fluid secretions. That's why it is coming as a cell which is composed of this unicellular glands, and rest of the glands we call them as this particular element as the multicellular glands. Now coming about this particular duct, as I mentioned, the lumen is different in case of this particular duct system, in case of this particular organelle glands. Now if this particular gland which is having this particular pattern, so in case of this particular duct, if it is one duct system, if it is present, we call them a simple kind of duct system or simple gland. If we have the more than one duct system, we call them as compound glands. So if this particular gland, for example, if you say this is a glandular tissue is there, which is coming out with this particular single channel of the duct which is penetrating and taking up the secretions from here. So with this kind of thing, if it is existing, we call them as simple gland. And if we have this more than one, that means we have a main duct and as well as a accessory duct is as well present. We call that as a compound gland. Now this particular thing which looks like we have one duct system which may be just like a branching, and along with that we have an accessory duct which is present as well, and this particular gland is kind of draining it. So this kind of things, more than one duct system, if it is there, we call them as compound kind of gland. Whereas the single one, if it is there, we call them as simple kind of gland. Now this particular gland, as I am saying, simple or compound, the look of the cell Based on that, we can call these as different names. Like if this particular cell which is present in this particular glands looks like tube and it is a single duct is there, we call them as simple tubular kind of gland. If it is flash shaped, we call them a simple acinar. If it is mixed of this tube and as well as this particular acinar or vase shaped, we call them as tubulo-acinar. Makes sense? So based on how it is look like, we just classify it, right? Now, do I have to know all the details of different types of this particular, what this particular gland, example name of this? No. We just have to understand this particular concept, how we are naming it, how we are addressing it. Now, if you just remember this particular address pattern, then we can just have an understanding how and why this particular thing is named like simple tubular or compound tubular or compound acinar or acinotubular, etc., etc. Right? So, these are the basic understanding of this particular glandular tissues whenever you are going to address, and along with that we are going to talk a little bit more detail about once we just going to project these particular elements. So, whenever you are saying this particular gland, we have to talk about the cells, and these particular elements are there which is having a cells which is secretory cells, we call them a secretory unit. Along with that we have some helper units as well. So, this helper unit we call them as the secretory assistant unit, we call them as myoepithelial cells which is pumping distance. We should have a duct or may have a duct or may not have a duct. Based on that we nomenclature it. If the duct is one or a many, we just classify it based on this. If this particular cells which is present in here looks like a flask or looks like a vase, or if it is a mixture of there, we call that particular names accordingly. If that particular gland is producing some kind of typical pattern of secretions based on this particular how the cell is behaving, like if the whole cell is dying, if the portions of the cell is shedding off, if this particular secretion is coming at the nature of exocrine pattern or which is expelling out, based on that we can classify it accordingly. And based on these particular classifications, we understand these particular cells are producing some kind of functions which is either producing hormones or enzymes or any kind of chemical substance that is modulating some kind of physiological function. That's it. So, these are the things. Now, whenever this particular whole entity, you are seeing that we are going to address that this is a glandular tissue. So, we are going to say that the parenchyma element of the glandular tissue, just like in the organ we have mentioned. So, if I say that parenchyma, what should be your idea about knowing parenchyma? So, parenchyma should be consist of this secretory unit, as I am saying, the cells which is present within it, and the duct system which is present on it. Clear? So, parenchyma is this unit, we call them a structural unit which is composed of the cells and the duct system. That means the secretory unit along with the duct system, if we are considering that as an exocrine organ. Now, along with that, we just going to talk about the stroma. So, these two words we are going to use, that stroma. Stroma means the gland is composed of some kind of sheathing or ensheathing things are there, covering. We call them as capsules of the gland. And we see that many a times the capsule are not restricted to the outside. It may be just penetrating the gland itself and going into and splitting down this gland into smaller quadrants, we call them as lobes. So, that particular stroma, if you just going to mention, if you using that word, that should be coming to your mind that stroma means, that means this capsule along with that parenchyma thing which is penetrated by this particular capsule, which is in case of the organs we may say that the trabeculi. You remember that the splenic tissues, thymus tissue, you use the word trabeculi along with the blood vessel trunks. So, this particular stroma is basically whenever we are addressing it, we are addressing that particular capsule of the gland which is covering it, and that particular capsule is penetrating the parenchyma and splitting into smaller chambers, we call them as lobules or lobes. Clear? So, these are the entities regard to this particular gland. So, whenever you are going to see this particular gland, next subsequent times we are going to see, we are just have to identify this particular element. Now, talking about the cellularity of this particular glands, if you are seeing at the cellular level, which is known as this particular two elements, we are going to see this particular in the glands, we call them a salivary gland, as mucinous gland, and as well as this particular serous things. These are the last element that we have to address over here. So, we have to look into this particular cells which is present in this particular acini and how this particular element is coming on. So, this particular gland, for example, this is one and this is a duct system you are seeing here. So, this particular element, you see this particular gland which is known as the serous element. The serous cell, typically you see that it looks like triangular in shape. So it looks like pyramidal or triangular in shape whenever you are looking at it. So roughly this particular element, which is serous looking gland or serous. Element. Whereas in case of the mucinous or mucin secreting gland, you see this particular cells, if it is present, the lumen is wider. That's why I am mentioned over there. There are several branching or unbranching pattern and subdivisions of the ducts also there. We'll talk later on. This particular gland, which is the mucinous gland, which is present, the cells usually are of pyramidal or circular, are of circular nature, or kind of like a elements which is present like the circular or semicircular element. So the secretions which is coming on from this particular element, which is cells, which is little bit rounded or oval or elliptical compared to this particular triangular or pyramidal shaped in case of the serous. So in case of the mucinous kind of gland, the cellularity is little bit different looking. It is a triangular, compared to this is a kind of mucinous which is circular or oval or a rounded appearance which will be there in the cells. Now they are also, these particular cells are present with this particular cells which is having kind of centrally placed nucleus which is there. In case of this particular, this element, we have a flat kind of nucleus at the bottom of this particular cells which is present, and it has a wide lumen duct which is present in it. So based on this particular duct, how it is lined by the cells, they can be classified in different, like a striated or intercalated, etc., etc. So those things makes things complex, but again we have to learn these particular basic elements. So let's move into these particular slides to understand this particular cellularity and what I have mentioned. That makes some sense if you see these particular things with pictures and some visuals on it. And later on, as we, so this is what we talk about, glands which is present, how it is coming out, how it is branching, and how this particular element is coming with this particular channel system, and how this is things is coming out. Two basic cells which is present in here, that's what you have to know. This main cells, which is the secretory element, which composed of this particular cells, which is the largest cell which you seeing here. Here you can see that this particular thing is acinar cells, which is having a triangular shape and narrow thin lumen. And on top of that, we see that this particular cells, which is pumping cells, which is myoepithelial cells, pumping the secretions out of these particular cells and getting into it. So we have a mixture of this particular thing. This is a kind of thing which you are seeing here is acinar, whereas compared to this particular cell, as you are seeing here, is circular or oval in nature. So this is a mucinous cell. So this is a mixture of the mucinar or acinar pattern. So this is a mixed kind of gland which you are seeing here, and the ducts which is present in here. You see that this particular duct cells are over here. This region we call them a striated duct. This particular striated duct lined by the cell which is columnar kind of cells, tall cells. Compared to that, you see that it is narrowed down by this particular cell which is cuboidal cells. We call this element as intercalated duct. So which have got different cellular pattern lining this particular ducts, and based on that we just like talk differently about this particular the duct system. But anyways, so these are the basic ducts which you are going to classify: unicellular, multicellular, presence of duct if it is there, exocrine, endocrine, and the manner of secretions if this particular cells is shedding off, merocrine, which is exocytosis, which is expulsion of the fluid which is coming like this, apocrine, apical part of the gland is shedding off along with the secretion, we call them as apocrine glands, and we have the holocrine gland where the entire or whole cell is shedding off once this particular secretions is coming out. So based on this is one of the basic classification we can do that. Now talking about the exocrine gland, it can be as like simple gland and it could be compound. If you have this unbranched simple duct, we call them as simple gland. If it has more than one duct, we call them as compound, and if it is branched, then we can call it based on this particular how this particular acini or secretory unit is looking like. If this thing's looking like tube shaped cells are there, we call them a simple tubular or coil tubular or branch tubular, simple branch or unbranched acinar. So based on this how these particular cells within the secretory unit are, we classify it. So if it is compound, that means more than one ducts are there, and if it is branched, we call them as branch tubular, branch tubular, branch acinar, compound acinar, tubular acinar, based on this particular basic classifications which is there. So if we have a single duct like this, and if this things breaks down or have more than one duct, we call them as branching. So this is a compound variety and this is a simple variety. So this is how these particular things are classified based on simple and compound variety. Simple, but this doesn't have the functional difference. They are producing the same functions, only the look is different. That's why we are addressing it differently. So if this particular gland nature of the secretion is coming, which is protein rich fluid in nature, we call them as serous kind of gland, which is serous secreting fluid are there. That means the cells that which is producing the fluid which is water in nature and protein rich in fluid. And this particular serous gland is composed of this acini, we call them as serous acini. That means the functional unit which is there, and it has a cells, as I mentioned, it looks like triangle or pyramidal shape. Compared to this particular thing, we have this particular acini. You can see that this is kind of like the cells which you're seeing here. The central part of this is the duct where it is narrow. Its channel is very thin. You see that? The central part. And the cell, how does it look like? Triangle or pyramidal in shape. And they have the middle or lower part occupied by the nucleus, and rest is filled up with this zymosome pattern which containing the compound which is the fluid which is present in it. So depending on how much content it is there, it is staining accordingly likewise, right? So this is how this particular element is looking like. Compared to this one, if you see that the lumen depth which is moving from here to here. So if you see this particular serous acini which is pycnotic, taking too much of stain, that means the fluid which is present in here is rich in this protein which takes too much of stain. Compared to this particular gland lumen, you see that this is narrow slit compared to this is a wider bore. So and as well as this particular cell, if you seeing that it's triangular, but it has a roundy shape which is visible in most part of this, which is having a like a cellular part which is like a less pycnotic or less stained, so which has a rich in mucin which is not taking up or not picking up enough of this particular stains which is coming of it. So these are the types of the acini, and you have a mixture of this which is maybe just like the serous part which is lying on here, and the mucinous part is lying on bottom, and myoepithelial cells which is this flat cell. So there are the difference between this particular myoepithelial cells which is a flat kind of like a spindle shaped cell and which doesn't have any flesh whatsoever. It's only actin myosin filaments are there. The cell cytoplasm filled up with this element which is producing this. So mucinous gland which is thick mucoid secretions which is having that, and this particular secretory unit having a pyramidal shaped, but it has a kind of like a circular pattern, so which is wider lumen which is present as a hallmark of this particular glands which is there. And we have the mixture of this particular element, mixed gland, where you have to see this mucinous acini along with this particular serous component together. So compound of this particular gland is coming together as a nature of the fluid which is mixed up with the serous and the mucinous pattern. So this is like a picture of the salivary gland which have got like mixture of this particular element. You see that this particular element which is taking up too much of like a stains, this is a serous element which is there, compared to this one which is like a white stain. Whenever you seeing that, it is looking like, this is a higher magnification you are looking at, this should be looking like snowflakey appearance. That means looks like snow is inside, like white material which is present inside, which is the mucus, which looks like a pattern we call them a snowflake appearance. And as well as this particular element, we can see that is a darkly stained where you have the plenty of the zymosome particles which is attracting too much of stains in it. So this is like basically how we divide that. And if you are just like going to talk about the difference between the serous cell and this particular mucinous cells, which is this particular element which is present on it. Serous acini, how it looks like, and mucinous acini, how it looks like. So these are the basic classification that you know. Now this is what we talking about the other functions. We call them as paracrine and autocrine glands. Secretions coming from it affecting the neighbor cells or affecting the cell. If it is like controlling this particular same cells or same element, we call them as autocrine kind of glands. If it is affecting nearby or nearby neighbor cells, we call them as paracline kind of glands, which is present and modulating some kind of physiological functions. And along with that particular thing, we have this particular autocratic signaling. That means like this particular things which is coming out of these secretions and affecting these receptors which is present on this region and controlling the secretions of this gland. We call this particular autocrine signal mechanism. So this particular autocrine signal mechanisms, we see that in case of like a blood vessels which is present with this particular signaling pattern, and we see this particular element controlling some kind of like a vasomotor substances. That means it's regulating this particular flow of the blood and the blood vessel caliber in the capillary level. In physiology, you will be learning about this particular cell microsome. And this is what you are talking about, this particular goblet cells, which is a single cell unit or one cell element, which is shape of this particular thing, looks like a vase, which is narrow at the bottom and above over there. This is a magnified version which is placed over here. The upper part is filled up with the secretory element, and you can see that it looks like white. That means it is filled up with this mucin. That means the lubricating pattern cells which is present on here, and the bottom which is have got cytological element which is having a cell which is present at the bottom of this, and we have the cell organelles which is present in the middle portions of this particular gland occupying it. So this element, as we are seeing that particular GI system, we will be going to see the plenty of this goblet cell placed inside this particular GI like epithelium or epithelial lining. So this element we call them as goblet cell, which is a hallmark of this unicellular glandular tissues. So this functions of this mostly is secreting the mucus, as we are seeing that mucus thing which is not taking the stains and looks transparent. We call them as snowflakey appearance. This is present in the epithelium of the GI system, respiratory system, etc., etc. Now, this is how it looks like. You see that this particular element in the, this is a kind of like a gland which is present in the GI system. This is getting down into, we call them as the duct system. Within this duct, we see that this is the element we are seeing that within the cursor over there, with white spots are there. This white spot are the goblet cells which filled up with the mucin element. As we go down, we see that they are isolated. So these are like a glands which is present in here, secreting the mucus, which is the lubricating functions over there. So this is in short about the general features of a gland that we need to understand about this classification, mucinous and the serous variety, how to differentiate between them, simple and the tubular, simple tube, and complex or compound branch variety or unbranched variety. And whenever you are seeing that, you have to identify what kind of like a glands you are looking at. If it is salivary gland, you will be seeing this particular salivary gland, and this particular salivary gland may have a serous pattern, may have a mucus pattern, or may have a mixed pattern. If you are seeing this particular pancreas, which is a largely kind of like a capable of producing two elements, like it's a endocrine organ and as well as it's an exocrine organ. So whenever you are going to see this pancreas, we will be addressing that. Whenever going to see this particular GI system, we will be going to see that some kind of like a glands. Now, the glands are, as you are seeing here, every organ can have glands. So the glands may be placed within this part of a organ itself. That means if you are seeing or studying any kinds of like organ, just like last time we studied about this particular organs which is like a GI system or any kind of respiratory system, there also we see the glands, and some of these particular glands may be as a glandular organ. So gland can be identified as a part of a different organ or collections of an organ which is present, like any kind of gland which is capable of secretion, like GI system is filled up with this epithelium. So epithelial cells are there. Epithelial cells are of different nature, and as well as at the bottom side which has a lamina propria, and deep to the lamina propria we have this mucus layer, submucous layer. Those layers may be filled up with some kind of glands. So isolated scattered glands may be there in a kind of organ piece, or maybe the gland itself has to be identified, just like glandular tissue, like salivary gland, just like this particular gland which is known as the pancreatic gland, etc., etc., or thyroid gland which is an endocrine gland, or parathyroid gland which is a typical endocrine gland which is present in it. So in an examination, you may be just like tested in glands in two ways. Maybe just like gland may be asked as a part of this organ as a whole. That's what kind of glandular tissue you are seeing at, like it may be just like a salivary or pancreatic tissues. That could be one specimen, or maybe given this particular organ which has a gland in it in some of the layers of it, right? So that particular layer, what the particular kind of glands is there, that can be also be identified as an organ identification spot. Okay. So this is the theoretical basis of this glandular tissues. Now next day onwards, we will be moving on to the glandular tissues, like we will be starting with this particular glands. That is, first one is the salivary gland, and next day we will be talking about this particular, the pancreatic ducts or pancreatic glands. Now, how many days we are left with before we go for the examination? Alright, so musculotendinous organ present in between the thoracic cavity and the abdominal cavity, partitioning it. and this particular diaphragm have got like different domains. So first we talk about the clinical thing about diaphragm, because this is one of the very vast important structure or organ that we must understand. So clinical thing is about diaphragm is that the injuries to the diaphragm is very threatful in a sense, because if it is not working properly, we have a altered lung function. That means the patient who has this particular error in the diaphragm or functioning of the diaphragm is struggling with these respiratory functions, which is filling of the lung and emptying of the lung. Now we understand this particular filling of the lung, that means it is inspiration, that means we are breathing in, but at the same time when you are breathing in, that has to be come out, we call them as expiration. But the expiration is a passive process. That what we have to keep in mind regard to this particular process of air getting in and air getting out. The passive process means we do not involve any muscle whatsoever in terms of throwing the air out of the lung when you are in a sitting posture like this. Now when I am talking, I am using some kind of muscles when I am talking, and whether I am walking or doing some kind of exercise. That means when it is required to have an assisted process, this particular diaphragm along with this particular some other muscles works as an expiratory muscles. Otherwise, in a quiet breathing, we do not need any expiratory muscles. So only the inspiratory muscles which is required for breathing in and breathing out. Fine. So this particular diaphragm is placed along with the bodies, and it has few components that you have to understand, that you have to address. So this particular diaphragm have got two bulges on the two sides. We call them as domes of the diaphragm. Right side there is a bulge and left side there is a bulge. Now you have to understand this clinical point about this particular bulging. So one bulging is bigger and one bulging is less bigger. Now we have to understand why it is bigger and what does it signify. So this particular elevation of the diaphragm, we call them as DOM. So these are the domes of the diaphragm, and in between these two elevation we have a flat part. This flat part we call them as CT, central tendinous portion. The more we go to this particular diaphragm to the peripheries or the rib side, it becomes fleshy. More it goes to the central part, it becomes tendinous. So the fleshy part is on a intercostal sides or as well as posterior side as well, and the central part is tendinous. Now as I am saying, this particular bulge we call them as domes of the diaphragm. How many bulge you have? Right and left. Now out of these right and left, these particular domes of the diaphragm are not lying at the same level. One lie at the higher level, one is less higher level. So right side dome and left side dome, you have to keep in mind the levels of the elevations or levels of this thing. So which dome of the diaphragm should be at a higher level and why? Right side one will be at higher level, will be bulged up compared to the left one. And what's your logic for it? Right side we have a massive organ. What organ we have? We have the liver. And the right side liver, we call them a right lobe of the liver, even bigger. That's why that thing pops up and pushes this particular right dome of the diaphragm to a higher elevation. That's a normal thing. So this particular thing, which is the liver is pushing out and right lobe of the liver is pushing these things up. That's why this right dome lying at the higher level compared to the left one. Now what lies under to the left dome of the diaphragm? So left side we have stomach. So we have this particular stomach. We have this stomach carved over here. We call them as fundus of the stomach. And along with that, we have the spleen. The part of the stomach which is present in here, we call them as F or fundus of the stomach, right? Now this fundus of the stomach is filled up with the gas, fundic gas. Okay, makes sense. Now, whenever this particular orientations is important for the clinical assessment of radiology or the patients as well whenever doing. So, this normal right dome bulge is a normal phenomenon. That's what you have to understand. Now, if this particular domes of the diaphragm not at the right proportion, that makes something unusual or abnormal to the patient, that you must strike to yourself whenever you are addressing something. So, this normal thing you have to keep in mind, right dome of the diaphragm, left dome of the diaphragm, not at the same level, right at the higher level because of the liver bulge. Now, there is a proportionate. So, this particular elevation is not that very significant, maybe just like a 0.5 centimeter or very small elevations are there compared to this level with this level. Now, it cannot be like this high and then this. So, this judgment of how elevated it should be, that elevation judge it should be there in your mind. So, it cannot be just like a too much bulged out or too much dropped down on the left side. This one element that you have to keep in mind. How we are going to do it? By seeing several of these particular diagrams, seeing several of these particular patients X-ray or these USG scans. You have to train your eyes. So, what is the normal quotient should be there? So, what is the normal range? Around that we will be accommodating this much of bulge is normal and this much is abnormal, right? So, that's what you have to understand, judge. Second thing is that, as I am saying, under to the diaphragm to the left side we have this fundus. So, this fundus part is filled up with the gas. Now, this particular gas is covered by this particular tissue of the stomach. It is not lying in empty space. It is lying within the organ. So, if this by any chance, if you see the presence of gas just immediate under the diaphragm in a sciagram plate, not in here, that also you have to judge. That means the gas under the diaphragm, if it is present, that's not a normal thing. The fundus gas, which has to be a normal thing, but that fundus gas has to be limited by this particular line, and then we can see this particular outline of this particular diaphragm. So, whenever you are addressing a sciagram plate, you have to read it properly. So, this particular dome of the diaphragm on the left side is visible, then you have a gap normally, then you have this fundus gas shadow which has to be covered or which has to be separated. Now, if you are seeing something which is the gas immediate under the diaphragm and no cleft or no space between them, that means it's an abnormal thing. You get it what I am trying to say? So, whenever you are clinically adjusting this particular entity to this particular diaphragm or the domes of the diaphragm, this entity should be clicking to your mind that this is normal or this is not normal. Now, the gas may not be present at all in the fundus. The gas may not be present at all the fundus, because if the fundus gas shadow is not there, that means doesn't mean it's not a healthy sign. But if the gas is present under the diaphragm, gas under the diaphragm is a disease state. It's an alarming state that we have to keep in mind. Clear? Good. Now, whenever you're going to talk about this particular parts of the diaphragm, we mentioned there are two domes of the diaphragm, elevations, and it has a central part. Yes. Now, that's a disease thing. That's a disease state. I am not going to state that thing. We have to understand a normal thing. And if it is gas on the diaphragm, it is that. That's a disease state. That's what you have to learn step by step. Not at this level. So, you understand the normal thing, and I break it down the analysis factors which is there. What is normal, what is not normal. If we do not have the fundus gas shadow, it's a normal thing that can happen. But the fundus gas shadow is absent, but that gas shadow is present under the diaphragm, that's a disease thing. So, gas under the diaphragm is a kind of threatful thing that we have to keep in mind at this time. Now, why? We'll learn later on. Now, talking about these particular parts of the diaphragm, we have the domes of the diaphragm and central part of the diaphragm which is depressed. Now, this particular central part of the diaphragm, on top of it, we have this particular cardiac tissue lying in here. So, we have the heart, and heart along with this particular tissue, we call them as covering of the heart. We call them as pericardium. So this pericardium is bridged with this particular central part of the diaphragm, and then we have these particular hearts or chambers of the heart which is present on it. Now, if you are seeing this particular diaphragm as an organ, whenever it is given to you, you have to identify this diaphragm superior surface and the inferior surface, upper surface and the inner surface, right? Upper surface means that's a thoracic surface, and under surface that means the abdominal surface. So you have to separate it, which is upper surface, which is lower surface. By looking at it, you may not be able to identify it unless until you look into the central part of the diaphragm. So this particular central part of the diaphragm has to be anchored with the tendinous portion which is fitted with this particular pericardium. So this particular pericardium has to be fitted on it. So the pericardium should be present on the superior surface of the diaphragm or thoracic surface of the diaphragm. So that makes this particular identifications of the diaphragm is clear for us, which is superior surface of the diaphragm, which is inferior surface of the diaphragm. Clear? So it has a superior surface, it has an inferior surface, and diaphragm has two elevations, bulge, we call them the domes of the diaphragm, right dome, left dome, and central depressed part, which is central portions. And as we move to the peripheries, we see the muscular things coming up on the diaphragm. As we move to the central part, we lose the muscle and it becomes more tendinous. Along with this particular component, there are two elements which is present in the diaphragm. We call them as crush of the diaphragm. C-R-U-X. So there are two crux of the diaphragm. Right crux of the diaphragm and the left crux of the diaphragm. Crux means leg. As if diaphragm is standing on the leg, we call them as crux of the diaphragm. So it has a right crux of the diaphragm, that means right leg of the diaphragm and left leg of the diaphragm. So these crux of the diaphragm are muscular. This is muscular. So right crux and the left crux both are muscular element. So if you see this particular diaphragm, which is maybe looking like this, and the crux looks like this. These are the two crux which is bulging out like this and which is anchored to the posterior side of the diaphragm. So anterior end and the posterior end of the diaphragm is identified by this. Anteriorly it is smooth and curved down, and posteriorly it has an attachment, we call them as crux of the diaphragm. This crux is tiny ribbon-like structure which is going on the back, and this particular crux at its diaphragm is standing on it. This crux of the diaphragm right side and the left side is there. Right crux of the diaphragm is stronger, thicker, longer than the left one. And this right side, this crux are anchored to the midline bones. In the midline, what bone we have? The vertebra, right? The part of the vertebra is lying here in this lumbar region. So we have the lumbar vertebra, we call them as L1, L2, L3, L4. So we see this particular crux of the diaphragm which is anchored to this particular midline vertebra, L1, L2, L3, whereas left side crux is coming on L1 and L2 attachments there. So it has an attachment which is anchored to the bones, intervertebral disc and this vertebra to it. So this crux is nothing but the legs of the diaphragm. Apparently it looks like it will be standing on it. So this is kind of parts of the diaphragm. And along with that we can classify it central part of the diaphragm, peripheral part of the diaphragm, upper surface, lower surface, anterior end, posterior end can be classified based on this. Good? Now, so once you see this particular diaphragm as it is coming on, within this particular diaphragm there are three openings are there. They will be seeing three openings are there. We call this opening as major openings of the diaphragm. What this major opening is made for is that the structures which is present in the abdomen, if they have to move to this particular thorax, or the thoracic content, if you have to have continued down to the abdominal cavity, they has to pass piercing through the diaphragm. As this content of the structure, mostly vascular or tube-like structure, they are going down or coming up from this upper thorax or this abdominal thoracic region. To transit them, we need some natural opening through this particular diaphragm. So this particular natural opening which is found around the major tube structures which this particular thoracoabdominal content has, we call them as major opening of the diaphragm, right? So these major openings of the diaphragm are three. There are three major opening of the diaphragm. One for the passage of the food pipe, the esophagus which is there. Other round tube-like structure we have in the thorax which is the trachea. Do the trachea go down to the abdomen? No, we do not need this trachea to go down. So, it splits before it reaches to that sternal angle, it splits down, goes to the lung. So, we do not need a opening for the trachea, but the esophagus has to go down to the stomach. So, it has to pass through. So, we have an opening for the esophagus. We call them as esophageal opening of the diaphragm. Then we have these two blood vessels which is present to it. One is the venous system, one is the arterial system. So, for the artery system, we have this aorta. So, aorta we call them as the thoracic aorta. The thoracic aorta has a couple of parts. We call them as the ascending aorta, then arch of aorta, then it drops down into descending aorta. Then it drops down, passing through, go to the abdomen, it changes the name, we call them as abdominal aorta. So, this thoracic aorta goes down through that particular opening, it has to be known as the aortic opening. So, that particular opening within this diaphragm, we call them as aortic opening. Similar to that, we have a vein which is coming from this pulling of the blood from the lower extremity, the abdomen. We have this particular vein which is coming, we call them as vena cava. So, this vena cava coming from the bottom side of the body, we call them as inferior vena cava. If that particular vein which is giant vein pulling all the blood from the upper part, we call them as superior vena cava. The superior vena cava is present in the upper part of the body. Lower part of the body is inferior vena cava. Now, inferior vena cava has to reach to the heart. Heart is present in the thoracic region. So, we have to bypass through or cross through this particular partition, diaphragm, has to pierce through to reach to this heart, or else it cannot reach. So, to pass through this particular, the diaphragm, it has to have an opening there. We call them as vena caval opening of the diaphragm. So, this particular vena caval opening of the diaphragm, aortic opening of the diaphragm, esophageal opening of the diaphragm, these are the three major openings of the diaphragm that it has. So, the three major opening of the diaphragm so we call them as inferior vena cava, esophagus and aortic opening. Now, this particular opening is lying in this sequel. So, this opening is not lying at the same vertebral level or the same level. Just like domes of the diaphragm, they are not just like lying at the same level. One is higher, one is lower. This opening within this diaphragm not lying at the same level. This opening lying this particular region, this particular opening, we call them as inferior vena caval opening or vena caval opening, is lying at this level of T8 vertebral level. That means thoracic 8th vertebral level, that particular level, that particular opening is there where this piercing of this diaphragm is coming on. Next is this opening, which is esophagus. Is we give a gap of 2 vertebra. So this particular esophagus level is lying at the level of the vertebral level of thoracic vertebra T10. We call them as T10 vertebral level. At this level, this opening is there. And the last one is again 2 space that or 2 vertebral space is T12. So at the level of T12 vertebral level, another opening is placed within this diaphragm, which is known as the aortic level. So we can understand this particular diaphragm is not a flat structure. That's like, it's like a parachute. So that particular parachute is there. Part of parachute is bulged out, part of parachute is bulged back, and in the central part it has a thing which is anchoring in the middle part. So as a result of this, the piercing of the structure lies at the different levels. Clear? So we have to remember this particular sequence of the structures, which is major opening passing through. We remember that. I keep forgetting these things. So the labels of it. So I made a like some kind of thing which keeps me reminding you about this particular level. So this sequence I memorize. So I eat apple. So I memorize it like that way. So I can memorize I eat apple, and then I place this particular vertebral level like this. So I keep it. It's like childhood habit of keeping these things in mind, right? So if I remember this sequence, then I can place the vertebral level 8, 10, 12, 2 space vertebral level and going on it. So this is about the major openings of the diaphragm. Along with that, there are some minor opening of the diaphragms up there. There are several. So we memorize the major opening of the diaphragm and minor opening of the diaphragm. They are made for passing of some kind of minor structures, like we call them as splanchnic nerves, lesser splanchnic, greater splanchnic. Those are the nerves that is passing through. So these are the minor openings there. Now these are the major opening which is transmitting this particular content or these structures along with it. Now along with this particular major openings, which are the main structure is passing with, some minor structure or some other structures also pass through it. So likewise, if I give an example, say for example inferior vena cava, right? Through the inferior vena cava opening, it transmits the inferior vena cava. Along with that, we have the thoracic duct. So that thoracic duct passes along with this particular inferior vena cava. So this is a other structure which passes through these particular structures. So for example, esophagus. So you see that esophagus is passing through this particular T10 esophageal opening. Along with the esophagus, we have the two nerves which is running through. We call them as vagus nerve. The vagus nerve going to supply, which is parasympathetic nerve, go to supply all the parts of the GI organs which is present in the abdomen. We call them as right and left vagus. So what it does, the esophagus is a collapsible tube like that. On the right side and left side of that, we have the right vagus and the left vagus traveling along with that. So it covers or make a nest of this particular network and travels along with it and gets inside from thorax to abdomen. So this vagus nerve starts from this particular brain, comes to the thorax, makes a plexus in the heart. After making a plexus, it goes down to this particular esophagus, makes a connections between them, channel network, and then it passes through the esophageal opening, gets inside this abdomen and supplies the abdominal viscera. So it is traveling down along the esophagus. So this is how I remember. Talking about the aorta, this particular aorta, accompanying by aorta, we have a vein which accompanies. We have a vein which do not have any mate, which do not have any pair. We call them as azygous vein. So this azygous vein, which do not have a pair, which runs from the abdomen, which has a connections with the inferior vena cava, pierces through the opening of this aorta, runs to this part and drains into this particular superior vena cava. So this azygous vein, along with this aortic opening, along with the aorta, it passes through. So along with this particular content structure, it runs through. So these are the theoretical aspects of this particular major openings of the diaphragm. Now coming to this particular other aspects of the diaphragm, about this interesting part of it is nerve supply and the blood supply. So diaphragm is a musculotendinous organ. Now this particular diaphragm is innervated by nerves. So these nerves are somatic nerves. Because this diaphragm is innervated by the nerves, we call them as the somatic nerve, we call them as phrenic nerve. The phrenic nerve is having this right phrenic and the left phrenic, which is two of them. Right side supplied by the right phrenic, left side supplied by the left phrenic. Now before that, we have to understand a little bit about this diaphragm. Now this diaphragm develops from the part of the tissue, we call them as septum transversum. This septum transversum is a part which is present around this particular cervical region of the fetus. Now we are going to talk about the septum transversum tomorrow. When you are going to address this particular development of the fetus, we will address the septum transversum. It is a tissue which is present around the neck region. Now that particular tissue which is present around the neck region, eventually by this particular developmental evolution or developmental process from the neck, it is pushed down to the thorax region. So when it was developed at the beginning, it was there in the neck region, and whenever it is in the neck region, it receives the blood nerve supply from this region, from the neck region. So the nerve which supplies the septum transversum receives this particular nerve from the cervical region. Now this particular cervical region, the septum transversum supplies here, we have this root value of C3, C4, C5, which is the root value of phrenic nerve. So C means cervical region, the diaphragm lying at thoracoabdominal region. So that's why when this particular diaphragm was initially made at the throat region and later on pushed down to the thorax, it drags the nerve supply where it receives from. পৈতের মতো নিয়ে চলে এসছে, পেয়েছে প্রথমবার ইনারভেশন, ছাড়বো না আর, পেয়েছি যখন যেখানে যাবো যাই ওই প্যারাশুট নিয়ে নেমে এসছে। So that nerve, phrenic nerve, supplying in the thorax region, it's like that you are moving, migrating to some different discipline. Why you are pulling me? Well, no, you come with me. So that thing, which is the phrenic nerve, it receives the nerve supply in the thoracic region. That's why it has a root value of C3, C4, C5. So ওই জায়গা থেকে টেনে নিয়ে চলে এসছে কোথায়? থোরাক্সের রিজিয়ন। কোথায় থোরাক্সের রিজিয়নে? ওপেনিং দেখতে পাচ্ছ কোথায় আছে? T8, T10, T12, মানে অত নিচে নামিয়ে চলে আসছে। তো যখন সেই জন্যই দেখবে যে thoracic nerve, phrenic nerve has a long course running through the mediastinum all the way coursing down. So right side phrenic and left side phrenic drags this particular nerve where it is originated from in the thoracic region, which is the right and phrenic region, which is thorax, which is the C1, C3, C4, C5 region, which is basically in the shoulder region. এই জায়গাটা শোল্ডারের যে রিজিয়নটা, এই রিজিয়নটা হচ্ছে আমাদের ওই রিজিয়ন C3, C4, C5, দ্যাট রিজিয়ন থেকে টেনে নিয়ে চলে এসছে। সুতরাং আমাদের কাঁধের যে নার্ভ সাপ্লাই আর আমাদের ডায়াফ্রামের যে নার্ভ সাপ্লাই কিন্তু সেম। বোঝা গেল মজার গল্পটা? টেনে টেনে বাড়িয়ে দিয়েছি ফাইবারগুলো, নার্ভ সেল বাড়েনি, অ্যাকশন জেনারেটগুলো দাঁড়িয়ে দিয়েছি। Understood? Fine. Now coming from here, this particular septum transversum and this particular innervation, as I am talking about, is phrenic nerve, right phrenic nerve, left phrenic nerve for the dome of the diaphragm. Now, what kind of nerve it is providing? What kind of nerve this phrenic nerve is, that we have to know. It's a mixed kind of nerve. What do you mean by mixed nerve? It is capable of showing some muscle. It is also sensitive guy. মানে প্রেমও করে আবার অ্যাকশনও করে, তাই তো? মানে যখন দরকার হবে কেলি টেলি দেবে, আবার যখন দরকার হবে ফুল নিয়ে দাঁড়িয়ে পড়বে। তার মানে সেন্সারি অ্যাকশনসও আছে, মোটর অ্যাকশনসও আছে। তার মানে if the phrenic nerve is burning with some kind of irritation, it will be crying, and if it is required to have pumping and thumping, হলে আমি করে নেব। So the motor contractions of the diaphragm is also produced by the phrenic nerve. Likewise, the sensory innervation. If the phrenic nerve is irritated, the diaphragm will be crying. Clear? So it's a what kind of nerve? Mixed nerve, right? Along with this phrenic nerve, we have some regional nerve supply. That means diaphragm তো অত দূর থেকে এসছে, লোকাল যেখানে এসছে তারাও বলছে যে এসে যখন পড়েছে আমাকে তো কিছু করতেই হবে, ফেলে তো দিতে পারি না, ঠিক আছে দে দুটো নার্ভ সাপ্লাই দিয়ে দেও। So the nerves which is this intercostal muscles is required with the intercostal region, যে জায়গায় আছে সেই জায়গায় না দেখে দিয়ে দিচ্ছি, আচ্ছা ঠিক আছে দিচ্ছি, কিন্তু বেশি দেবো না, আমি খালি বাইরেরটা দেবো, ভেতরের তোরা নিজেরা বুঝে নিবি। So the peripheral margins of this diaphragm is supplied by the intercostal nerves, which is that particular region begins with. The intercostal nerves which is required to this particular region is supplying that particular region only. So the margins of this particular phrenic nerve is supplied with predominantly the sensory innervation is predominantly coming through the intercostal nerves, the central part of the diaphragm, which is predominantly receiving the nerve supply through the phrenic nerve. Am I clear? Clear or not? Okay. Now here is a catch. Where is the catch? Now phrenic nerve, এটা খুব ভুলো মন, ভুলে যায় কাজ করতে করতে। It's a very forgetful nerve. So sometimes it miss the stop and they can come back. Oh, ভুলে গেছি বাস থেকে নামতে, something like that, right? So what happens with the phrenic nerve innervations? What is does? It actually, when it's developed, it pierces the septum transverse. It pierces the transversum and course some distance. Then it recovers. Oh, maltaকে তো সাপ্লাই করতে ভুলে গেছি। So what phrenic nerve supplies here? It penetrates the diaphragm and then recurs back to supply this. So as a result of this, phrenic nerve supplies the upper surface of the diaphragm as well as lower supply of the diaphragm. Understood what I am saying? It pierces through, goes down, supplies it. So both of the phrenic nerve has a recurrent branch which supplies the undersurface of the diaphragm as well as it supplies the upper part of the diaphragm as well. Complex হয়ে গেল তাই তো? তাহলে সামারাইজ করা যায়। So consider this is diaphragm, this is the peripheral part and this is the central part. Peripheral part supplied by intercostal nerves. Central part is supplied by phrenic nerve. What kind of nerve it is? Forgetful nerve. Mixed nerve, yes, mixed forgetful nerve. পিয়ার্সেস ইট, ওপর থেকে এসে পিয়ার্স করে মেজে ফুড়ে চলে গেছে, তারপরে খেয়াল হয়েছে ও আচ্ছা ঠিক আছে, তারপর সাপ্লাই দিচ্ছে, ঠিক আছে। তো it supplies the under surface of the diaphragm, it supplies the top of the diaphragm. Now what kind of nerve, phrenic nerve is sensory and the motor, ঠিক আছে। Now এটার একটা significance আছে, to understand this forgetful nerve about this phrenic nerve. Clear about the nerve supply? Now blood supply. Now this particular blood supply of the phrenic nerve is regional. Blood supply বলছে আমি অত যেতে পারবো না, তুই যা পড়িস করে নিবি, যা নতুন জায়গায় যাবি, নতুন ঘর বাঁধবি, ওখান থেকে নতুন বাপ মা শ্বশুর শাশুড়ি যাকে জোগাড় করি তাদের থেকে পয়সা নিয়ে খাবি দাবি, আমাকে জ্বালাবি না, সামথিং লাইক দ্যাট। সো as this particular thing, septum transversum course down, settles down to this particular region, it gets the regional blood supply. So the blood supply which comes from the thoracic aorta, which is descending down, and this abdominal aorta which is going down. So it takes this supply from both, মানে নিজের বাবা আর বউয়ের বাবা দুজনের থেকে ব্লাডটা নেয়। কিরকম? It receives the blood from the descending thoracic aorta and also receives the blood from the abdominal aorta. So the branches we call them as superior phrenic artery and inferior phrenic arteries. These are the phrenic arteries which supplies this diaphragm, which are branches from the descending thoracic aorta and abdominal aorta. So descending thoracic aorta gives a branch which is known as superior phrenic artery, and the abdominal aorta gives a branch which is known as inferior phrenic artery. Along with that, আশেপাশে যাকে পাড়া প্রতিবেশী যাকেই পেয়েছে দিন কিছু সাহায্য করুন। সো ইন্টারকস্টাল ব্লাড ভেসেলস অ্যাজ ওয়েল দিন না দু চারটে ব্লাড ভেসেল পেরিফেরি থেকে দিয়ে গেছে। সো ইট টেক্স এভরিওয়্যার, খুবই অমায়িক লোক, যেখানে যা যা পাবে সব নিয়ে জড়ো করে একটা জোগাড়ের জিনিস জানিয়ে রেখেছে, ঠিক আছে। এই জোগাড়ের যন্ত্র কি বলছি, হেভি আইএসি লোক। কিরকম বলছে, আমি একবেলা কাজ করবো আরেকবেলা ছুটি। কিরকম বলছে যে আমি খালি ইন্সপিরেশন করবো, এক্সপিরেশন তোমার দায়িত্ব। So that's what I'm saying. So this particular diaphragm is a inspiratory organ. So the inspiration of the diaphragm, inspiration of the physiological mechanism is assisted by the diaphragm only, along with assisted by the intercostal muscles and anterior thoracic wall muscle. Kon anterior thoracic wall? Pec major, pec minor. Pec major, pec minor helps in assisted working. এরকম দৌড়াচ্ছ, রান করছো, so when you are running you need the extra supply, you need the intercostal muscle to work along with the diaphragm, you need some kind of pectoralis muscles also working. দাঁড়িয়ে হাঁপাচ্ছ, ফিক্স করেছো, so pectoralis muscle is contracting and it is making this expanding lung out and putting the air, right? Now why you are doing the quiet breathing, diaphragm is making no actions, বললাম একবেলা কাজ করে একবেলা ছুটি। So lung has to work here. Lung is filled up with the elastic recoil nature. Lung alveoli গুলো নিজে collapse করে নেয়, নিজেই রান্না করে বার করে দিচ্ছে। তো all the oxygen which has been extracted and then elastic tissues which is present in the elastin fibers, which is connective tissue in the lung, has pumps out the air which this lung has, and it pumps the air out when it cannot. If this particular elasticity of the lung, if it is destroyed by some diseases, there is a disease we call them as emphysema, which is happen to be triggered by some chemicals, happen to be triggered by the cigarette smokings, happen to be triggered by some kind of like a pathological process where these elastins are not working well. It loses the elasticity. Then this air cannot be pumped out. Then this diaphragm is working. Then the intercostal muscles are working. When you have to force the air out, all the air which the lung has to be forced out. Then you need the anterior-abdominal wall muscle. The anterior-abdominal wall muscle, which is required to pump out all the air. Which muscle? Six-pack muscles. যেটা নেই আর fat pack হয়ে গেছে আমাদের, but six-pack muscle, the anterior-abdominal external oblique muscle, which is present in here. That also is kind of assisting the forced expiration. That means lungs এর মধ্যে যা হাওয়া আছে তুই বার করে দিবি, তখন lungs এর মধ্যে হাওয়াটা ঢোকে বেরোয়, পুরোটা হাওয়া ঢোকে বেরোয় না। টাইডাল ভলিউম বলে একটা থিং আছে, মানে ওই একটা অ্যামাউন্ট অফ এয়ার ঢোকে বেরোয়, পুরো হাওয়াটা আমরা বের করতে পারি না। পুরো হাওয়াটা বের করতে গেলে আমরা ওই এক্সট্রা কাজ করতে হবে। তখন কাজ করতে গেলে ডায়াফ্রামকে বলতে ঠেল ভাই, কিছু ঠেল, বা তুইও ঠেল আমিও ঠেলছি, তখন অ্যাবডোমিনাল মাসলকে করতে হবে, বলে তুই আর একটু ঠেলে দে আমি তাহলে একটু করে দেবো, এরকম কাজ। সো দিস থিংস কিপস অন কোলাবোরেটিং ওয়ার্কস। সো নর্মাল কোয়াইট ব্রিদিং, what are the muscles working? Exercise, what are the muscles working? That what you have to prepare it. Accessory muscles of the respiration, that is different, including the neck muscle. Whenever you are breathing in, the neck muscle also helps out. The these muscles, sternocleidomastoid, scalene muscles, neck muscles. We call them as scalene, good, bad, ugly brothers. Scalene's anterior, scalene's media, scalene's posterior. These are the three muscles, right? So, anyways, they are helping this out. Now, normal breathing mechanism. পড়েছো, lecture হয়েছে নিশ্চয়ই. So, what happens when you breathe in to the diaphragm? যখন breathing in করো, diaphragm কি হয়? উপরে ওঠে না নিচে নামে? Diaphragm contracts. When the diaphragm contracts, it flattens. When it flattens, it goes down. ঠিক? So, right down of the diaphragm, left down of the diaphragm goes down. Breathing in, moves up. Now, injury to the phrenic nerve. If the phrenic nerve, we have two of them, right side phrenic nerve, left side phrenic nerve. If the injury to the phrenic nerve happens, say, এই সাইডে phrenic nerve টা তুমি দিয়েছো কেটে, অপারেশন করেছো, বলছো হেভি অপারেশন করে দেবো, তারপর নার্ভটা কেটে দিয়েছো, right phrenic nerve is gone. What happens to the right side diaphragm when you are breathing in? Right. So, normally what happens? Breathe in করলে ডায়াফ্রামটা নামবে, রাইট সাইডে ডায়াফ্রামটা ঠিক আছে, ব্রিথ ইন করছো নামবে, লেফট সাইডে ডায়াফ্রাম ব্রিথিং করছো নামবে, নড়বে না। নর্মালি কি হয়, এই নামছে তো না, নামছেই না, পতাকার মতো উপরে উঠে যায়। So, the unhealthy side, this particular diaphragm moves up during inspiration. This kind of movement we call them as paradoxical movement. Paradoxical movement of diaphragm. This can be judged through skygram. তুমি একটা এক্সরে তুলেছো একটা পেশেন্টের, যার শ্বাসকষ্ট হচ্ছে, ব্রিদিং ইন পোস্টারে বলেছো যে ব্রিদিং ইন পোস্টারে তুলতে হবে, ব্রিথ ইন করবে, সেই সময় ছবিটা তুলবে। তুমি দেখলে যে রাইট সাইড অফ ডায়াফ্রাম যেটা রয়েছে সেটা নিচের দিকে চলে গেছে, আর লেফট সাইডের ডায়াফ্রাম উপরের দিকে চলে গেছে। কতটা উপরে? অনেকটা। তার মানে গন্ডগোল। নর্মালি কি হয়, রাইট ডায়াফ্রাম কি থাকে, উপরে থাকে, লেফট ডায়াফ্রাম কি থাকে, একটু নিচে থাকে, তাই না? বিকজ অফ দ্য লিভার। তুমি বলেছো, এক্ষেত্রে দেখছো যে লেফট ডায়াফ্রাম তো একবারে উপরে উঠে যাচ্ছে, আর এইটা উল্টো দিকে নেমে যাচ্ছে। সো দিস থিং উই কল দেম এজ প্যারাডক্স। প্যারাডক্স মানে অপোজিট, যেটা হওয়ার কথা ছিল অপোজিট হয়ে বসে। সো দিস পার্টিকুলার থিং ফেনোমেনন উই কল দেম এজ প্যারাডক্স। নাও ওয়াই দিস থিংস মুভস আপ? এতে এক জায়গায় দাঁড়ানোর কথা, উপরের দিকে উঠছে কেন? ওয়াই ইট ইজ মুভিং আপ, স্কেলিং হাই? ইফ ইট ইজ নট ওয়ার্কিং, ইট শুড বি স্টেইং এট দ্য সেম লেভেল। লিফট খারাপ হয়ে গেলে কি উপরের দিকে উঠে যায়? কি করে? দাঁড়িয়েই থাকে, বোতাম টিপছে, দাঁড়িয়ে আছে। So this thing should be like that, right? তাহলে উঠে গেল কি করে? কঠিন ব্যাপার। পেটে ভাত না পড়লে এটা বোঝা যাবে না। তাহলে ভোরে ভেবে টেবে পরের দিন বলবে, ঠিক আছে? প্যারাডক্সিক্যাল মুভমেন্ট অফ ডায়াফ্রাম, হোমওয়ার্ক থাকলো। হলো? এবারে লাস্ট ক্লিনিক্যাল পয়েন্ট, ডায়াফ্রামকে কে নার্ভ সাপ্লাই করে? ডায়াফ্রামের উপরে কে থাকে? হার্ট থাকে। আর কে থাকে? লাং থাকে। লাংয়ের জামার নাম কি? প্লুরা। হার্টের জামার নাম কি? পেরিকার্ডিয়াম। এদের কে কে নার্ভ সাপ্লাই করে? হোমওয়ার্ক, nerve supply of pericardium, nerve supply of pleura. আচ্ছা লেগ না ভাই, তুই এখন আর খাওয়ার আগে বলিস না, একটা বেজে গেছে, আর বেশিক্ষণ বলা যাবে না, ডায়াফ্রাম দেখাতে হবে, দেখিনি চলে যাবে। হলো? এবারে নেক্সট কোশ্চেন অফ ডায়াফ্রাম রিলেটেড টু দিস। ওইটা হলো উপরে গল্প, নিচে কে থাকে? আন্ডার সারফেস অফ ডায়াফ্রাম লিভার থাকে, স্টমাক থাকে, স্প্লিন থাকে একটু দিকে, আর কে থাকে? স্মল ইন্টেস্টাইন থাকবে না, ওরা নিচে থাকবে। লিভারের সাথে একটা ছোট্ট গল ব্লাডারের তলার পার্টটা কি বলে জানিস, যেটা জিভ বার করে থাকে, ওকে বলে ফান্ডাস, ফান্ডাস অফ দ্য গল ব্লাডার। ঠিক আছে, গল ব্লাডার তুললে দেখবি জিভ বার করে আছে, তো ওটা হচ্ছে ফান্ডাস অফ দ্য গল ব্লাডার, দেখা যায়। ঠিক আছে, ওটা নর্মাল। এবার গল ব্লাডারের যদি অসুখ হয়, লিভারের যদি অসুখ হয়, স্টমাকের যদি অসুখ হয়, তাহলে কি এই 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 ফেনিক নার্ভ ইরিটেটেড হতে পারে। কি করে? কারণ ডায়াফ্রামের তলার সারফেসটা কে সাপ্লাই করে? ফেনিক নার্ভ। তাহলে এই যদি অসুখ হয়, ফেনিক নার্ভগুলোকে ঘষা টসা লেগে গেলে অসুখ হতে গন্ডগোল হবে, তো ফেনিক নার্ভে ইরিটেশন হয়। এবারে কি বলেছি, ফেনিক নার্ভ ইরিটেশন খালি থোরাক্সের প্রবলেম হলেই হবে না, অ্যাবডোমেনের প্রবলেম হলেও হবে। বোঝা গেল কি কি কারণে বলছি আমি? লজিকটা বোঝা গেল? গুল মেরে যাচ্ছি না? বেশ। এবার ফেনিক নার্ভে যদি ইরিটেশন হয়, ফেনিক নার্ভে ইরিটেশন হলে আমার এই জায়গাতে প্রবলেম হওয়ার কথা। অ্যালং উইথ দ্যাট, ফেনিক নার্ভে ইরিটেশন হলে আমার শোল্ডার রিজিয়নও ব্যথা হয় বা হতে পারে। ক্যান ইট বি এক্সপ্লেনেবল? If you have an irritation of phrenic nerve, it is like what? It is going to have a trouble in the thoracoabdominal region or epigastric region. Along with that, it might have pain over the shoulder. Is it possible? If it is yes, how come it is possible? Explain that thing. We call them as referred pain. মানে মারবো এখানে, গাছ পড়বে শোল্ডারে। সো দিস রেফার্ড পেন সেন্সেশন করতে হবে, তারপরে পরের দিন এসে বলতে হবে। রেফার্ড পেন, শর্ট নোট প্রিপেয়ার করো, ফিজিওলজিতেই বলবে। ফ্যান্টাম লিম্ব সেন্সেশন বলবে, পড়াবে ফিজিওলজিতে। পা কেটে গেলে বলছে যে হ্যাঁ আঙুলের ডগাটা চুলকাচ্ছে, চুলকাতে তো আঙুলের ডগাটা আমার, এদিকে আঙুলটাই নেই, পাটাই নেই, কোথায় চুলকাও? আঙুলে চুলকাও। Phantom limb sensation. So something like that, we have a referred pain sensation. So you have to understand what is referred pain, when this particular referred pain phenomenon is going to take place. ঠিক আছে? So these are the theoretical aspects of it. Theory আবার হবে, হয়তো প্রিপেয়ার করবে, পড়বে। ঠিক আছে, আর্টস ডায়াগ্রাম প্লেটে দেখার চেষ্টা করবে। ডোম অফ দ্য ডায়াফ্রাম, রাইট সাইড and left side, where it is lying, how much it is, at the different level it is lying. All right?